Hello, and welcome to the SNMMI Annual Patient Education Day. My name is Josh Mailman. I am the president of NorCal Carcinet Community, a neuroendocrine tumor patient support and advocacy community headquartered in Northern California. I'm also the inaugural chair of the Society's Patient Advocacy Advisory Board. And most importantly, I'm a net patient who, thanks to various nuclear medicine scans and therapies, have been living with this disease for over 14 years. This is the 10th year the SNMMI has held this event, and the second time we've done it virtually. There have been a great deal of advancements in nuclear medicine in the recent years, and we look forward to sharing with you the newest developments as well as a look into the future. Today's session is the first of 3 Patient Education Day events. The remaining 2 events will be held on the next 2 Saturdays. On August 21st, the event will address prostate cancer, and on August 28th, the focus will be on breast cancer. Our schedule today starts with a 15-minute session offering an introduction into nuclear medicine and radiation safety. We will then have 4 speakers on various net topics for approximately 80 minutes, followed by a Q&A period. Most of our speakers will be joining us at the end to take part in the Q&A session. If you would like to submit your questions, please use our Q&A application platform at slido.com/pednet or slido.com/pednet. The address should now be appearing on the screen below me. All the questions will be asked anonymously using your phone, tablet, or computer, and we'll try to get to as many of your questions as possible. There's also a short 6-question survey that we would appreciate if you had a moment to complete. This event is being produced under the direction of the SNMMI Patient Advocacy Advisory Board, which includes representatives from 14 different disease-specific advocacy groups. And a note to any physicians or techs that may be joining us today. We are so pleased to have you here, but please note there are no continuing education credits being offered today. Finally, before I introduce our first speaker, I would like to thank our event sponsors. You'll find them listed at our website at snmmi.org/PED, where you can also find some excellent patient materials that they have provided. Our industry sponsors are Advanced Accelerator Applications, Blue Earth Diagnostics, ITM, GE, and Lanthus Medical Imaging. I want to point out that all sessions are being taped, and SNMMI plans to place edited versions on their website shortly. As a reminder, this is for educational purposes only. Please discuss your treatment plan with your NET team. So let's get started. Our first speaker is Dr. John Sunderland from the University of Iowa. Dr. Sunderland serves as the director of the university's PET Imaging Center and is a professor of radiology in the Division of Nuclear Medicine, a professor of radiation oncology, and a professor of physics and astronomy. He is also the chair of the SNMMI's Research and Discovery Domain and co-chair of its Clinical Trials Network. He's going to share an overview of nuclear medicine, molecular imaging, and radiation safety. Please help me welcome Dr. Sunderland.
Hi, my name is John Sunderland. I'm a medical physicist at the University of Iowa, and I'm going to spend the next 15-20 minutes or so going over what nuclear medicine is, with a little bit of radiation safety kind of folded in towards the end. So here's a roadmap where we're going. We're going to start just with a very brief comparison between anatomic imaging as compared to what nuclear medicine and molecular imaging is all about. Then we're going to get into what nuclear medicine actually is and how it works. We're going to go to what nuclear medicine is used for. We're going to do some diagnostic applications and therapeutic applications, which is a new and upcoming an exciting area, and then follow with some radiation safety considerations just at the very end. So to start off, just for context here, what you see on the left-hand side of the screen are 4 very common anatomic imaging techniques that you're familiar with. So for example, MRI in the upper left really is an image of the hydrogen density in your body. If you go to angiography right next to that, you inject just a little bit of radioactive opaque liquid into the veins, and you can get exquisite, very high resolution images of the vasculature in the heart and other places by passing X-rays through it. If you look at CT down in the lower left, That's taking x-rays that are going through the body at about 1,000 different angles. We can put those together to create highly detailed anatomical images, which you see there. Ultrasound uses ultrasound waves that reflect back, give you real-time images, for example, of fetuses and babies. But all of this stuff looks at anatomy in the human body, whereas what we have in the area of molecular imaging is we're actually looking at function. We're looking at biochemistry. What you see on the left-hand side is an image of glucose metabolism. So we're not looking at structure here so much as we are, ooh, look at the brain. The brain has a lot of activity. The heart has a lot of activity. If you look more importantly in the chest, you can see the tumor where you have cells that are dividing rapidly. They're metabolizing glucose rapidly. So we can see very clearly what that is and distinguish what might be a cyst or some other lump from actual active tumor. If you look in the upper right, we have a brain scan, which is distinguishing a normal brain. We're looking at dopamine storage here on the left, Parkinson's disease on the right. Anatomically, these two structures look the same on an MRI or a CT, but here we can see very clearly that the function is compromised. And if you look down below that, we're looking at perfusion of the heart, what parts of the heart are actually getting blood. We're looking at function here. So on the left-hand side, anatomy, right side, function, which is our nuclear medicine molecular imaging biz. So we're going to go from there and get into what is nuclear medicine and how does it work. So in all cases, when we do a nuclear medicine study, we are administering a tiny, tiny quantity of drug that has a radioactive atom attached so we can trace its path through the body. So what you see here on the left is a molecule, it's a glucose molecule again, that happens to have a fluorine-18, a radioactive atom attached. This is like my kids, they carry around cell phones, and I can track where they go all over town because the cell phone is transmitting radio waves and the like, such that I can see where they are. Similarly, when we get radioactive decay, we can place where that molecule is in the body. So we are tracing where the glucose goes in the body over time. Now, what we're doing is we're injecting a tiny quantity. And when I say tiny, I mean tiny. When we do one of these studies with this radioactive glucose, we're injecting about 1/1,000,000th of a single grain of radioactive sugar. So the mass quantity is small. There's almost no possibility for side effects or anything like that. This is a tracer methodology. And then we use special scanners to detect the gamma rays from the nucleus of the radioactive atom. Now, we're not doing magic here, and we're not doing anything unnatural. We're using what Mother Nature gave to us. You're probably all familiar with the periodic table you'll see here, and all familiar with carbon, which we see here. There's two stable isotopes of carbon, carbon-12 and carbon-13. But if we put one extra neutron into that nucleus, we end up with carbon-14, which is radioactive. It's unstable. It decays with a half-life of about 5,000 years, and this is what we use for carbon dating. If we take a neutron away, then we end up with carbon-11. We now have too few neutrons and too many protons. It's unstable. This has a half-life of 20 minutes, very unstable, but we can use this and image it with positron emission tomography. And in fact, what you see in the lower right here is an image of C11 choline, which allows us to detect prostate cancer quite sensitively. You can see in the groin area, a little tiny dot, which is where a hidden prostate cancer is metastasized. So this is just to give you a little bit of a harbinger of where you're going to be going in this invention, not just this, but other talks that are coming. We're going to look at radiopharmaceuticals because in nuclear medicine, we only see what our molecules are targeting. And so what we have on the left is F18 fluoroestradiol, FES, which is very specific for not only breast cancer, but estrogen receptor positive breast cancers, which will help a physician guide a particular kind of therapy that will be effective to patients who have this particular kind of breast cancer. In the middle, we have F18 DCFPYL. This is a PSMA prostate cancer imaging agent, recently approved just as FES was just to the left. This was just recently approved, a highly, highly sensitive way to detect the spread of prostate cancer. This is going to be a game changer in the way prostate cancer is managed. This too was just recently approved and is hitting the market. And on the right is copper-64 dotatate. We've had dotatates approved before, but not with copper-64. Copper-64 is different because instead of a half-life of an hour or two, it has a half-life of 12 hours, which means they can make it centrally in St. Louis, and they can ship it by FedEx anywhere in the country, even up as far as Alaska. It'll be there the next day, and so now everybody has access to this, which is used for somatostatin receptor imaging and neuroendocrine tumors. Once again, highly specific to cancers and to molecules. Going to go very briefly over the three kinds of radioactive decay. There's negative beta decay when there are too many neutrons. There's positron decay when there's too many protons, and there's alpha decay, which we're not going to discuss today. There's really only three of them. The particles that they emit, they only, just an electron or a positron, they really only go a millimeter or so. We don't worry about those so much, but we almost in all cases get a gamma ray at the same time. And gamma rays are very penetrating. They go way more than a millimeter, and they can actually make it outside of the body where we detect them with our scanners. And if they're positron emitters, because they have too many protons, not enough neutrons, we use a PET scanner. If they decay by beta decay, we use a SPECT scanner, which is below. PET is usually a little bit higher resolution and a little bit higher sensitivity, but they're both highly useful and both great imaging. So this is how it works. We generally inject in the arm, although in this center video, you can actually see it being injected in the foot, and you can actually see how, and this is what happens when we inject one of these radioactive radiopharmaceuticals into the body. It goes into the vein, it goes to the heart, it goes to the lung, it spreads to the different organs, to whatever physiology that molecule is supposed to go to. So this is going to start again in a minute, and we'll look at it again. But then on the right, we image. The imaging takes on the order of 15 minutes on a PET scan, 30 minutes on a SPECT. So once again, if you see this going up, you see it going into the lungs, into the heart, going into the rest of the blood, so it can be delivered. Here we're only 1 minute out right now, and pretty soon you're going to see it starting to go into the kidneys. The kidneys are getting it. It's filtering it out. The bladder just filled up. It's going to the heart. You can see the brain is using the glucose. You can see the heart is using the glucose. But if it were a different agent, the distribution would be different. And that's what we do. So, going to launch from here into what nuclear medicine is used for. So I'm going to go through some diagnostic applications, current and upcoming, and then some therapeutic applications, which are also actually quite exciting and game changing. This is just a brief slide with some bread and butter stuff that nuclear medicine imaging things that we've been doing for decades, frankly. We've been doing the cancer imaging with FDG and PET. We look for cardiovascular disease using SPECT imaging or PET imaging. I'm showing this pulmonary embolism imaging because on the left-hand side, this is one we don't inject. This is a radioactive gas that we inhale. We use that in combination with an injectant dose to see A, where air is getting, and B, where blood is getting, and we use that together. On the right-hand side, we're looking at, once again, the movement disorders, but we can look at amyloid imaging with Alzheimer's disease, etc. These are all exciting but old. What I'm going to briefly go over now are things you're going to learn about in a little bit more detail in subsequent talks. But I just want to introduce you, first of all, to this F18-FES, which I mentioned before. This is fluoroestradiol. This was just recently approved within about the last year or so. It's used in the detection of estrogen receptor positive lesions as an adjunct to biopsy in patients with recurrent metastatic breast cancer. This helps guide the physician to the appropriate treatment for this particular patient. It is approved by FDA, and it is also being reimbursed. Here we're going to go through, the next two are both PSMA prostate cancer imaging agents. This first one is gallium-68 PSMA. This is approved, although it's only commercially available through the University of California, San Francisco, and UCLA at this point in time. They're the ones who submitted the application to the FDA, so those are the people that are approved. Although there are academic institutions, the University of Iowa is one of them, who continue to perform these studies under an FDA-approved mechanism, an IND, on a temporary basis until we get access to these commercial agents, because FDA wants people to have access to drugs that are safe and effective. This is approved, and it is reimbursed by CMS and generally by private insurers, but you generally, as in all of these agents, you pretty much need pre-approval. This is a similar PSMA agent for prostate cancer. This one is labeled with F18. F18 has a half-life of 2 hours. as compared with gallium-68 with 1. This one is much more easily transported from central production. This is, and it's not a university that submitted this, it's the company. This is newly approved just within the last few months. It's available now in some major metropolitan areas, and the availability is rapidly expanding. As I said, this is going to be a game changer for prostate cancer management. And here, as I mentioned, is the copper-64 dotatate. Gallium-68 dotatate has been approved. This does functionally exactly the same thing. The point here is this is available nationwide. They can get it to any hospital that's licensed, that's actually licensed to have it in the country. And that's exciting and a big boon to the neuroendocrine tumor community. And the last one I'm going to point out, these are 3 brain imaging agents, Alzheimer's disease agents that image amyloid. These have been approved, frankly, for almost a decade, but they haven't been used because Medicare, CMS, does not reimburse for them. They don't reimburse, not because they don't work, but because there is no therapeutic out there for Alzheimer's disease. Now, with the tentative approval of a drug, Aduhelm, that you've probably heard about in the newspaper, it is possible that these are going to be seeing widespread use to make sure a patient actually does have Alzheimer's disease before they have access to that very expensive therapeutic drug. And there are other good therapeutic drugs that are in the pipeline right now that are doing functionally the same thing. So this is another area of nuclear medicine imaging where it might manifest itself in order to help with management of patients in a very common and devastating disease. I want to just spend a minute on therapeutic applications here. So we don't just diagnose with nuclear medicine, we can actually do therapy. Now, fundamentally, we know that very large doses of radiation can kill cells, or at the very least damage the DNA so they can't divide anymore. This is the foundation of external beam radiation therapy that's been a staple of cancer therapeutics for more than 50 years now. But it kind of makes you think. Because here on the left-hand side is a gallium-68 dotatate scan. So this is a patient with widely metastatic disease in the body. There's no way that you can do surgery on a patient like this or anything. What you really like to do is to target just the tumors, which is exactly what this gallium-68 is doing. It's going straight to the tumors and almost nowhere else. So it makes you think, what if instead of injecting a tiny bit of gallium-68 dotatate, you injected a lot of lutetium-177 dotatate? Same molecule, same targeting, but lutetium-177 has a half-life of about a week. So what happens here is the radiation goes to the tumors, it sits in the tumors for a week or 2 and blasts the tumors, the neuroendocrine tumors that they're bound to, with radiation to the point where hopefully you give the tumors a lethal dose, and what you end up with is a patient who, in this case, is virtually disease-free. This is almost like magic. Not all patients respond like this, of course, but this is a very effective way to treat metastatic disease. Neuroendocrine tumors are an orphan indication, which means there are not a whole lot of those. Prostate cancer is a much more common disease. Just to follow up, lutetium-177 dotatate was approved in 2018, and it is being used all over the country now for the therapy of neuroendocrine tumors. But moving on to PSMA for prostate cancer, once again, we have this imaging agent that goes very specifically to the tumors. So the question is, what happens if we label it with a long-lived radionuclide, lutetium-177, with that half-life of almost a week, and we inject a lot of it? So here are 6 cases, A, B, C, D, E, and F. In the first image, you see in red where the gallium, the imaging agent, shows where the tumor was, and then in B, you can see after therapy what the response was. So once again, the first 3, you see the disease almost completely eradicated. In D, E, and F, you see partial response, but certainly dramatic response. And so this is all exciting. This is not approved yet, but the phase 3 trial, the one that they're going to use to try and get it approved, has functionally completed. They've done their preliminary analysis, and they have met their statistical endpoints of prolonged overall survival of patients who receive its treatment. So they will be applying to FDA, and I wouldn't be surprised if in a year or so that this will be available to the general population, which is a huge step forward. Lastly, just spending a couple minutes on radiation safety considerations, just with regard to nuclear medicine. I just want to let you know we're all being exposed to background radiation even as we speak. Cosmic rays from space are coming down. We have radioactivity in Earth. We have radioactivity inside our bodies, and as well as the radon that's in our basement. We know about how much radiation we get. We get about 1 millirem per day just from background radiation. So if we bear that in mind, we get 1 per day just in general. I want to put that into context. So 1 per day is background, not harmful. If we go up to 500,000 of those units of radiation dose, your whole body at once, that can cause acute harm and even death. So that's on the high side. If we go down a factor of 10 to 50,000 millirem, bearing in mind we get 1 per day, and we get that all at once, then we believe we can see a very, very slight increase in the downstream risk of cancer. It's not a sure thing. In fact, it's only barely blip above the normal cancer incidence rate. But that's about our level of detectability. Maybe we might be able to go down to 40,000 and detect a little bit of an increase there, which is why we go down a factor of 10 still to go 5,000 millirem per year, which is what we believe is safe for radiation safety workers at hospitals in nuclear power plants and stuff to be exposed to. So the technologists that are doing your scans, they're radiation workers, and at least at the PET center here, our technologists get on the order of 1,000, 1,500 millirem per year, which, by the way, is on the high end of what patients get for a single nuclear medicine procedure. We conservatively assume that even though we can't detect an increased rate of cancer at these low rates, we conservatively assume that maybe they can. So we just assume that less radiation to the patient is always preferable as long as we get the right information out. Okay, this is just putting this all into context. For a chest X-ray, you get about 10 millirem. That's about 10 days of background radiation. And for a nuclear medicine thyroid scan, you get approximately the same thing. On the other end of the spectrum, for FDG, that's one of those glucose PET scans, along with a CT study at the same time, you'll get between 1,000 and 2,000 millirem or so, which, as I mentioned before, that's about what our technologists get over the course of a year. Still well within our safety margins. That's the kind of range that we're talking about for clinical scans. How much radiation would be considered too much in the grand scheme of things? Well, in our biz, the answer is more than is necessary. We don't want to give more than that. In all cases, these are prescribed drugs when we inject these radioactive radiopharmaceuticals into you, and the benefit of the imaging study far outweighs any potential risk. Each of the imaging procedures takes a certain amount of radiation to perform appropriately. This is well studied. We know what that is. Using too much radiation dose, it leads to unnecessarily radiation dose to the patient. But using too little may not provide enough information, which may be harmful in and of itself. If we're too worried about radiation, we don't give you enough, and our images are cruddy, and we don't detect the cancer that we're trying to see, then we're actually doing harm by not giving you enough radiation dose. So each imaging procedure is optimized for the medical question, the equipment being used, and the patient, and this is what is practiced universally in the United States. The SNMMI has initiated 2 dose optimization campaigns, the Image Gently and the Image Wisely campaign. One's for children, one's for adults, and both of these promote the appropriate procedure for that specific patient with the minimum amount of radiation dose necessary to provide the useful information that we're trying to get. SNMMI has a web page on these topics. It's snmmi.org/dose if you are interested in such things. And with that, I think I will conclude, and I hope you enjoy the rest of the program and the rest of your day. Thank you.
Thank you, Dr. Sunderland. That was an excellent introduction to nuclear medicine. A quick reminder that we will address your questions after all of our presentations are completed. Hi, I'm Josh Mailman. I'm the president of NorCal Carcinet Community. I'm also a member of the Patient Advocacy Advisory Board for the SNMMI, and I want to welcome you here today to our Patient Education Day on Neuroendocrine Tumors. I'm actually joined by a fellow patient and a fellow traveler down the PRT road, Bill Claxton, who just happened to be dropping by into my little studio. And Bill is the president of the Singapore CNETs, or the Carcinoid Neuroendocrine Tumor Society in Singapore. And, you're also a patient. You're a neuroendocrine tumor patient who had PRT really early on in 2007 in Erasmus in Netherlands, when this was really new and novel, early times. Do you want to describe that experience a little bit? And now, of course, it's available in Singapore, and people don't have to travel as far. And can you say what that's meant to people in Singapore? And by the way, welcome to California.
Thank you, Josh. When I was first diagnosed was in 2004, and started looking around for treatment options that maybe are sandostatin or analogs related. And then I discovered that the imaging technology was tagging isotopes to the peptide, and that Dr. Krenning and Dr. Kwekabom in Erasmus were doing radiotherapy with a therapeutic dose of lutetium. I had read studies on indium and yttrium as well, but lutetium seemed like the best one. And I had a challenge actually getting enrolled in the program because I didn't have sizable tumor burden in my liver. And at that time, it was a trial. And so they were admitting patients who had something that was measurable that they could shrink down. So I was very happy when I was told that an MRI documented a 1 cm tumor at the edge of my liver, sent it off to Erasmus, and the doctors there told me that I would be eligible to join the program. So in 2007, I started 4 rounds of lutetium therapy as part of the trial. And at that time, because of the trial, everybody was getting the same dose, and it was relatively high dose. There was no dosimetry done. So a young woman, a petite woman, would be getting the same dose as me. I'm, 6'1", 175 pounds, and my absorption would be different than a young woman. So it was interesting to see how all of this went. We would be brought in cohorts of about 8. And all of these patients felt that they were traveling to Rotterdam to get the best available treatment in the world. Some of them were referred by the Mayo Clinic. Some of them were referred from places in Europe, but most of them were not Dutch people. So we were, I think, in the first 3,000 patients that were receiving PRT in the world. And we were the first in Erasmus who were foreigners coming in.
Right. You were the first foreign cohort before there was, large multinational trials that went on.
Right.
And I know, how many treatments did you have back then?
So I had 4 cycles, and that carried over into 2008. And it was interesting because my initial surgery in 2004, there was some video documentation done that showed a lot of little small tumors around the abdomen. My tumor was at the ileum, the primary. So all of the spread was these small micronodules around the abdominal wall. And when I went for another surgery in 2010, after my PRT, the surgeon remarked that all of those little spots were completely gone. And so the PRT really works. I got an immediate quality of life benefit. I had a lot of energy and could continue working and all of that. But there were a few residual tumors that were sizable 2 cm or 3 cm. And I ended up going back in 2010 and having debulking surgery.
So now we look and we fast forward 12 years, we've had a clinical trial, which we're going to hear about today, NETTER-1, which was based off that 4 treatment type regime that you had in Erasmus. And we have an approval both in Europe. Dr. Herman is going to talk about that a little later as well. We have approvals in Europe, we have approvals in the US. And now, of course, patients, you're the president of the Singapore CNETs. Patients in your community now don't need to travel as much. I know I've come to Singapore to speak at the Singapore Nuclear Review, and I know that talking about PRRT is something that happens quite frequently there and is done quite frequently. So how has it been now that patients are able to have it? How has that changed
That's
what
right.
patients have done?
So in 2009, we established this group, Carcinoma Neuroendocrine Tumor Society of Singapore. At that time, there was no PRT, there was no CGA testing for blood test, and no gallium scans. And so we advocated with the physicians to really upgrade nuclear medicine to the higher standard. And Asians, as you know, are fast followers. So we followed what was going on at Bad Berka and in Italy and some of the leading centers of excellence in Europe. And so we did bring in CGA testing now. It's available for $100 in Singapore. We have gallium PET CT scans available for about $2,500. And I just went back and I did my 5th cycle and 6th cycle, and it was like out of pocket about $5,000 for each cycle in Singapore. And we have really good quality of service there from the Nuclear Medicine Center. So all the Asian patients benefit from these advances. Many come to Singapore, but now there are like 4 or 5 places in India. There is a new one in Malaysia, in Kuala Lumpur, and several in China.
So it's amazing. Today we're really going to be talking about the global advances because we obviously with Dr. Harriman and Dr. Singh will be talking about this, and it's such a pleasure. We're really going to travel the globe today. We're starting in Singapore. We're soon going to come back to UCSF before we move our way through the globe and see parts of Canada and parts of Germany. But I thank you so much for dropping into my little studio today and to welcoming all the patients to Patient Education Day. Thank you so much, Bill.
You're very welcome, Josh. Thanks for the opportunity.
I would like to now introduce our next presenter, Dr. Courtney Lawn-Heath. Dr. Lawn-Heath is a radiologist and assistant professor and assistant director of the Nuclear Medicine Residency and Fellowship Programs at UCSF. She is a recipient of the 2019 SNMMI Henkin Government Relationship Fellowship and currently serves on the Society's Breast Cancer Imaging Work Group. Dr. Lawn-Heath and I have worked together with doing presentations for NorCal Carcinet community. And really, one of the reasons we've asked Dr. Lawn-Heath to give this presentation is with some of the changes that are going on in due to the 21st Century CARES Act. We're now getting our radiology reports right away, and it's been confusing patients. So Dr. Lawn-Heath is really going to go through all of what we need to know about imaging in our reports. And we're so looking forward to your presentation, Dr. Lawn-Heath. It's all yours.
Thank you so much for that introduction. I really appreciate it. And hi, everybody. I'm Courtney Lawn-Heath, and I am a nuclear medicine physician at UCSF in the Department of Radiology. And just like Josh Mailman said, I'm going to be talking about some recent developments in nuclear medicine, kind of review how some of the imaging that we do for NET in nuclear medicine, and also hopefully give you a peek into how a nuclear radiologist like me puts together your imaging report. And first, I just want to explain what a nuclear radiologist is, just in case you're not familiar with the term. A nuclear radiologist is a radiologist and nuclear medicine physician. They are board certified in both specialties, and that generally means that after 4 years of medical school, they have done a 5-year diagnostic radiology residency and a 1-year nuclear medicine fellowship. Now, both radiology and nuclear medicine involves reading medical imaging, but they're a little bit different. Radiology gives us very important information about the structure of the body, like the anatomy, where things are, the size of things. One example is MRI, like this MRI through the upper abdomen. And another example is CT. Meanwhile, nuclear medicine is primarily interested in information about function. What kind of cells are we dealing with? Do they have a certain kind of receptor on their surface? How are they working? Examples of nuclear medicine include PET and SPECT. And the other piece that I love about being a nuclear medicine physician is the ability to do therapies using radioactive medicines like PRRT. Now, in a minute, we're going to review the kinds of imaging that we use in NET, like I mentioned before. But first, I want to talk about your imaging report. And to do that, I want to give some historical context here. So traditionally, diagnostic specialties like nuclear medicine primarily existed as specialty consultants, mainly to other doctors. So another doctor, like an oncologist, would come to a nuclear medicine physician. We were sometimes called the doctor's doctor. The oncologist would order a scan with a question in mind, such as, is my patient's metastatic disease stable? And then we would do our work, which involves scrutinizing every inch of an imaging study, and we would dictate a report that answered the oncologist's question. And now this report was usually written in very technical language because, frankly, it was written by one doctor for another doctor. And just like in any field, there's a lot of really specialized terminology you end up learning that lets two people in a specialized field kind of communicate about really specific things that there aren't always great words for in everyday language. So the oncologist would then take that, translate that technobabble for their patient. But now, in the modern times, through advances in therapy like PRRT, nuclear medicine physicians are able to have more of a direct relationship with patients, of course, in collaboration with other docs like oncologists. And that's one of the things that drew me to nuclear medicine. That's something I love about it. But it does bring up a challenge that I think needs to be addressed in my field, and that is how we make our reports. We are no longer writing for this single doctor audience, an audience that's comfortable with technical language and complicated things, which we all learned together in medical. It's easier than ever now for patients to access their own imaging reports. And we in nuclear medicine really need to start realizing that we're not just talking shop with our oncologists in our reports anymore. And I definitely acknowledge that. We no longer have this intermediary who's going to translate and contextualize all this information. Now, you may have heard of a federal law called the 21st Century Cures Act. This is a slide actually from my work, from a recent training presentation where I work, when we implemented a certain stipulation of that law, where traditionally radiology reports were held onto for 5 days so that the referring doctors had time to read them and kind of process it and speak with their patients about anything concerning. Now radiology reports, including nuclear medicine studies, are now immediately accessible as soon as they're signed by an attending physician. It was thought that this would reduce anxiety among patients because, frankly, waiting for your results for any kind of test can certainly be anxiety provoking. But so now in our patient portal, a disclaimer pops up when you open your imaging report. And this is what the disclaimer says here. But I'm kind of wondering, is this enough? I'm curious to hear feedback from the group about your experiences, because the most common reaction that I've been seeing to this in my practice at my institution, frankly, is more anxiety rather than less. For example, a colleague of mine recently got the following email from a patient whose PET CT he had read. The email said, "Dr. Colleague, FYI, I received my recent PET CT scan results directly in my chart last night, apparently before or at the same time as my oncologist got it. The report scares me and has me very upset. You should have just sent it to Dr. Oncologist first. It also wasted Dr. Oncologist's time, as she's very caring and responded to my MyChart inquiry immediately via phone on her way home from work, basically to talk me off the ledge, so to speak, because I was so upset. And yet she'd not yet been able to review it thoroughly herself first. When I talked to the oncologist about it, this is all she said. This law is killing us." And yet, there was an informal poll when I recently spoke at a NorCal CarciNet meeting, and 93% of the respondents said that they preferred to receive their imaging reports as soon as they're read. And so there's really been an interesting disconnect in what I'm hearing patients saying outside of my institution and what patients in my institution seem to be saying. Or maybe I'm only hearing from the ones that are upset by instant access, or I should say taken by surprise by the instant access. I'm not sure. This is an ongoing thing. If the institution where you get your scans has not yet rolled this instant access thing out. This is something that is rolling out nationwide. It is a federal law. And so if it hasn't happened yet, it will. So stay tuned. So in that spirit, I want to try to help demystify some aspects of your imaging report. So all the reports have to have the name of the scan and the date that it was done. So in this case, copper 64 dotatate PET CT, 8/28/2021, just hypothetically. We also have to say whether we compared the scan to prior scans or not. And now for NETs, because NET can grow so slowly, I always tell my residents to compare back 2 years or since the last major change on imaging. This is not something that every nuclear medicine physician knows to do right off the bat. Caring for NET patients requires some special expertise and going a little bit further back, doing a little more digging. The next part of the report is called clinical history. Now, this is supposed to be some background information about the patient's situation provided by the ordering doctor that will help the nuclear medicine doctor interpret and contextualize the findings on the scan. So here's an example. 57-year-old woman with well-differentiated grade 3 small bowel neuroendocrine tumor, status post-resection in September 2019 on long-acting octreotide. Now, that's very helpful for me to know as a nuclear medicine physician who's about to read this scan. But in reality, what we're often provided with is much less information than this. In some cases, almost no information. The nuclear medicine physician often has to find this information herself and kind of sort of reinvent the wheel, do their own detective work. Sometimes the only information we're provided is something as simple as evaluate or cancer. What kind of cancer? They're nice to know. Anyway, we end up having to do a lot of detective work. Or my favorite was initial staging for a patient for whom this was clearly like their 15th dotatate PET, and definitely not their initial staging exam. Probably the provider had been copying and pasting the same history for the last 15 scans. So anyway, long story short, we often have to do the detective work ourselves. So sometimes when you might see a slight discrepancy, as long as it's minor, between sort of the history that the nuclear medicine physician's been able to piece together from the notes, that's often the reason. But so finally, we get to the meat of the report with the findings section. I think of this section as a collection of observations that the nuclear medicine doctor has made from looking at the images. And I'm going to give an example of that. Then finally, the impression, the conclusion that the nuclear medicine doctor has come to after carefully considering all the findings. In other words, the impression is really it's the take-home message. It's the most important thing in the report. And it's basically saying, based on all these observations above, here's what I think is going on. The lung nodules have decreased in size. So then we'll give a good example. So for example, a right lower lobe nodule now measures 1 centimeter, previously 2 centimeters. Then we might notice the same trend in the liver. Based on that evidence and assuming that there's nothing growing anywhere else, we might conclude decreased size of lung and liver lesions compatible with response to therapy. In other words, based on my findings, my impression is that everything's getting smaller, and so I think it's responding. Ultimately, though, no matter how complicated the report might be, you have to remember that in most cases, the scan, right, is either going to be better, worse, or the same. There are really only a few options. Frankly, there is another option, which is sort of a mixed response where it's better in some places and worse in other places, but the most common thing is one of these 3 categories. So despite however many impression points there might be in the report or whatever, there is an overall gist that can be derived from it that is either better, worse, or the same. But I know sometimes it can be really hard to extract a clear sense of that, especially when it's written in a lot of technical language. Again, our field is still catching up here. But no matter what the report says, if you're reading it on your own, I'd urge you as much as possible to try to hold off on drawing any final conclusions until you talk to your oncologist, because imaging is ultimately just one more piece of data, along with other things like blood work, tissue samples, and symptoms. So your oncologist is going to use all this and more to put together a picture of what's going on and to develop a proposed plan of action. So if you read your report and you're tempted to panic, talk to your oncologist first. One recommendation I do want to make before we move on, though, is if possible, it's best to get all your scans at the same facility. I'll explain why. When scans are done at different facilities, first of all, they're done often with different techniques. Also, the nuclear medicine doctors at one place may not have access to the reports from the other facility. And the tumors that a doctor at one place talked about because she felt they were good examples may be totally different than the ones that the next doctor compares if she doesn't have the prior report. And that can sometimes make it difficult to pick up on long-term trends, like a tumor that's very slowly enlarging over many scans. Now, speaking of scans, I want to move on to quickly review the different kinds of imaging that we use for NET. A lot of this will be review for many of us, but I think hopefully this will help solidify some of this knowledge. This big shallow donut that I'm going to show you here is a CT scanner. Inside it is an X-ray tube, and it sends out X-rays which travel through the patient and hit the detector on the other side. The X-ray tube actually spins around the patient. Eventually, this leads to a high-resolution, three-dimensional image of the body. Now, these are some example CTs of the abdomen with IV contrast at 2 different time points that show us, among other things, the liver, the stomach, and the spleen. Now, what CT measures is the density of the body's tissues. And there's a scale that goes from air, which is the least dense, to bone, which is the most dense, with different kinds of soft tissues in between. Now, something that can present a challenge for any of us who are looking at CTs is how different certain tissues can look, actually depending on the timing of IV contrast. I'm going to show you a multi-phase CT of the liver at 3 different time points after contrast injection. So here's the same person, same slice through the liver, just different time points. Now, how many lesions do you see here? Do you see 3, 4? Actually, on this middle image, you can even see a few tiny ones that you can't see at the other time points. So I'm going to point out where those tiny little lesions are. They're pretty sneaky. So zooming back out, I show this to indicate how tricky it can be to catch everything at the exact perfect time point on every scan. And frankly, what is ideal timing to see one kind of lesion may not be perfect timing to see other kinds, which is a big part of why we often do these multi-phase CTs for neuroendocrine tumors. And that's also why many patients may get MRIs of the liver instead of or in addition to CTs. Now, part of the challenge of a radiologist or a nuclear medicine physician's job is to make sense of all this and try to take into account all that natural variation that might happen from scan to scan. It's part of our job, and try to separate that out from what might be a real change in a person's tumor status versus it's just slightly different timing on this scan. And now the vast majority of the time, we're able to make a confident decision about that. But this is part of why I always highlight the need for special training and experience when it comes to neuroendocrine tumors, whether the person is an oncologist or a nuclear medicine doctor. Now, I want to point out where CT really excels and where I recommend it most strongly, and that is in the lungs. These red circles are pointing out tiny 2 to 3 millimeter lung nodules that are just not going to be visible on MRI. They're too small. So ultimately, if you ever wonder, or if you sometimes wonder why you're getting so many different kinds of scans, it's often because different kinds of imaging are best for different parts of the body. CT is great for lungs. MRI is best for liver in many cases. And we'll talk about that in a second. So this slightly deeper donut here is an MRI scanner. This is the super noisy one that they make you wear ear protection for. It uses a strong magnetic field and radio waves to tell the different kinds of tissue apart from each other. So it's not actually measuring density like CT does. It's actually measuring kind of how the body's tissues respond to being in that magnetic field. And now, just like CT though, the timing of IV contrast can also impact how well we see certain lesions. So here, I'm going to show you a slice through one person's liver. Now, just like CT, the timing of IV contrast can also impact how well we can see lesions on MRI. So here's a slice through one person's liver, and then there's that same spot, same patient, just the only difference is a slightly different time point. We can definitely see a lot more tumors at this time point, right? Again, a really good reason to do multiple time point imaging here. Now I want to talk about a special kind of liver MRI imaging called so-called hepatobiliary phase imaging. Hepato means liver, biliary means bile duct, and this is a kind of imaging that can only be done with MRI and only with a special hepatobiliary contrast agent. And it's extremely helpful for us when we try to both find and measure liver tumors. So here's a view, just for comparison, of the liver with regular MRI contrast. Okay, and we can see a pretty faint lesion here in the liver. And compared to hepatobiliary contrast, you can see it's much more clearly demarcated, much more reproducible from one scan to another. Much more contrast between that lesion and the normal liver next to it. It's done between 15 and 20 minutes after injection. And the idea is basically that the normal liver looks bright and things that are not normal liver are dark. So So it's like very simple, almost binary. And this is the type of contrast agent we always recommend for NET patients, especially because tumors can grow so slowly over time. We want to get a really accurate measurement, and that gets us the closest. So now we're going to get into the nuclear medicine realm. This is a SPECT camera here. Now, normally, if you injected octreotide into your bloodstream, we wouldn't be able to see where exactly it went in the body. We would know it was there, but we couldn't see where it was. But if that little bit of octreotide was linked to a very tiny radioactive atom, we could take a picture of it with a gamma camera. If that yellow oval here were a person, the gamma camera can just sit in one place and just record all those tiny amounts of radioactivity coming from the body, and that produces what is called a planar image. If instead of letting the camera just sit there and record, we instead make it kind of rotate around the body, we can actually take a three-dimensional image of the body, and that's called SPECT imaging. Now, in the past, you would have encountered this kind of imaging if you'd ever gotten an Octrea scan. And this isn't done much these days, but it worked very differently from dotatate PET. Okay, so imaging was done at 4 hours and or 24 hours, maybe even as late as 48 hours. So you had multiple visits, and the radiation dose was higher than for a PET scan as well. This is what those scans looked like. Here's a dotatate PET in the same patient. And those arrows are pointing to liver metastases that actually are, unfortunately, are not visible on the Octrea scan because it's just not high enough resolution. So we don't see as many Octrea scans these days as a result of that. But you may still encounter it once in a while, and you certainly may encounter planar and SPECT imaging again in the future. At my institution and some other institutions, we do SPECT imaging the next day after each cycle of PRRT, actually. This helps us keep an eye on the tumors while patients are getting this treatment. And what I'm most excited about is that in the future, this kind of imaging is going to be used to see how much radiation is getting delivered to each tumor so that we can do something called personalized dosimetry. That is, we can give each person a dose of PRRT that's specifically suited to their specific amount of disease. So currently in the US, as you probably know, most centers give the exact same dose of PRRT to all patients, whether they have a lot or a little disease, whether their disease is like this, or this, or this, or this. And instead of that, in the future, we want to use post-treatment imaging to make sure that we're delivering the right amount of radiation to suit each different person's disease. Now, the next thing I want to talk about is PET, and that's something most of us know very well. In NET, we start with some kind of variation on octreotide. Then we add a little compound like DOTA, which acts as a little, kind of like a little basket to hold our radioactive atom. And then we inject that into the bloodstream, and again, just trace amounts. We let it distribute throughout the body. And the PET camera detects that very small amount of radiation in the body. And we get a picture of where all that octreotide went all over the body. But the real power of this kind of imaging comes when two things join forces. A CT that shows us where things are, and the PET, which shows us kind of what's happening in those tissues, giving us a PET CT. Now, it doesn't have to be radioactive octreotide, actually. We can do PET imaging of all kinds of different things in the body. And the images actually look super different, as you might imagine, depending on kind of what radio tracer we're using. For example, FDG, or sugar PET, it's just radio tracer. It's a radioactively labeled sugar. It just goes to tissues that happen to use a lot of sugar. And some kinds of tumors fit that description. It's actually the most common kind of PET study performed by far. You have to fast for at least 6 hours prior to getting the imaging study. In contrast, the so-called somatostatin receptor PET, that's the one using the octreotide. And dotatate is a great example of that, either gallium or copper. Fasting is not needed, but usually it needs to be scheduled before the next dose of long-acting octreotide. And these two doses tell us different things, and they can complement each other in certain cases. For instance, low-grade NET tends to have high dotatate uptake and low FDG uptake. And these tend to respond really well to PRRT. Higher grade tumors can have less dotatate uptake and more FDG uptake, and therefore tend not to respond as well to PRRT. So sometimes there's sort of an inverse relationship between dotatate uptake and FDG uptake on PET. Now, we've been using gallium-68 dotatate and DOTATOC PET for a number of years, But the most recent development, probably in the nuclear medicine world in the US, is copper-64 dotatate. So a new radioactive atom that we're attaching to dotatate. It was just FDA approved back in September 2020. Now, gallium-68's half-life is 68 minutes. Copper-64's half-life is 12.7 hours. So the idea is it might allow for easier nationwide distribution, which is certainly convenient. And importantly, copper-64 dotatate appears to have similar accuracy, at least in the literature. Overall, these agents are pretty similar, frankly, so I wouldn't worry if your next scan ends up being copper-64 instead of gallium-68 or vice versa. So really, in my opinion, there's no need to rush out and try to be the first kid on the block to get copper-64. Overall, it's a good scan, but it's a pretty similar scan with a pretty similar level of efficacy to gallium-68. I'll be very interested to see if more differences emerge between these two things as we see this agent start to get more widespread use in the US. And that's all we have time for today. Thank you so much for your attention. Thank you so much to SNMMI for having me, and have a wonderful day.
Welcome back. Our next session will be with Dr. Ken Harriman from the Clinic for Neuroendocrine Tumor Medicine at the University of Essen. I first met Ken at a LACNet event many years ago, way before Lutathera was approved, when we had our first discussions about Lutathera and its impending approval in the United States and how that would affect patient care. We've remained friends throughout the years, even if he's traveled back from UCLA back to Germany, and we seem to meet each other in the most unusual places. And now we're meeting each other in the middle of this flat screen Earth. But I thought it would be great to bring Dr. Harriman here today because not only can he give us a perspective of Lutathera and the NETTER-1 experience from his days at UCLA and implementing it after the FDA approval, but also the perspective, a global perspective of what they're doing in Germany and some of the things that are coming down the pike for nuclear medicine PRRT for neuroendocrine tumor patients. And without that, it's great to see you, Ken, even in this strange flat Earth, but the floor is all yours, and welcome to our conference.
Thank you very much, Josh. I'm really honored and pleased to be able to give this presentation. I have to admit that Josh is one of my big heroes because I've met very few people outside of the field of medicine who know so much about neuroendocrine tumors and especially PRRT, even far before the approval of Lutathera. And I'm very excited to spend a few minutes with you today and talk about the global perspective of PRRT with Lutathera. And this being said, I have to admit that I was not involved in any of the sites who committed to the NETTER-1 study, but I had the honor to actually treat the first expanded access patient of Lutathera in the US back in 2016. So I'm really looking forward to the next minutes. And to start off, this is my disclosure slide. You see there's not really much going on compared to other people. And here now we talk a little bit about the structure of my talk. In the beginning, I want to discuss to you why Lutathera, why do we talk about Lutathera, why is it so important, why is it going to be an important pillar in the treatment of neuroendocrine tumor patients. In the second part, I want to discuss a little bit how does Lutathera work. And then the third part, as Josh already indicated, talking about what comes next. So the landmark study, as I mentioned before, is the NETTER-1 study, and I'm sure many of you have heard about it. It was published in 2017 by Jonathan Strasberg in the New England Journal. And this shows you the progression-free survival curve. And in green are the patients who underwent 4 cycles of PRRT, and in gray, the patients who were randomized into the octreotide, where they received a high dose of octreotide, 60 milligram, also known as sandostatin. And what you can see here very nicely is that the curves are pretty much different from each other. And when we look at the corresponding 50% range here, you can see that indeed the patients who did not undergo PRRT already crossed this line at something below 10 months. In contrast, the patients who received PRRT 4 cycles, they didn't seem to cross the 50% line between 25 to 30 months. And when we look back, and this is actually indeed also what was published there in this corresponding paper, is that the median progression-free survival, as this 50% line is defined, was not reached for the PRRT group, and was 8.4 months for the patients who underwent octreotide high dose. And the corresponding hazard ratio, which is really important in addition to significance, is 0.21. What does it mean? In very easy terms, it means that patients who did not receive PRT had an up to 5 times higher likelihood to experience progression compared to the patient who received PRT. So this data was absolutely groundbreaking. I also want to show you very quickly the corresponding survival curves. Overall survival curves back then already announced that this is only an interim analysis, but even here you can very nicely see that the green and the gray curve are pretty much away from each other. It was back then significant. The p-value was 0.004 and a total of 14 deaths in the Lutathera group compared to 26 deaths in the group of patients who received high-dose octreotide. What does it mean again? And here we look again at the hazard ratio. It's 0.4. One way to translate the hazard ratio means in this case that the 60% lower estimated risk of death was found in the patients who underwent PRT. I always like to talk a little bit more about a factor. And in this case, it's really the case that 2.5 times was the likelihood higher to experience a death in the group of patients who were not randomized to the PRT arm. So PRT arm really goes along with significant better overall survival, at least in this interim analysis. Now, one of the nice things of PRT is that we treat patients with lutetium-177, which not only has a therapeutic component, which is a better particle, but also has an imaging component included. And the good thing is, and this is an example of a patient from the NETA-1 study treated in the UK, we can also show objectively, first of all, where did we deposit the radioactivity, but overall, we can also look how this kind of pattern changes over time. This is an example of a patient who underwent a total of 4 cycles of Lutathera. And you can see here on the far left, March 14, August 14, December 2014, and April 2015, that this patient, first of all, did not show any progression of disease, but even better, you can also see that the tumor actually decreased in size. And this in a patient over nearly 13 months, not only showing a stabilization of disease, but also really showing that the patient benefited from this therapy. And this, in this case, also defined according to RECIST, the imaging on the radiological scan, and he was even rated as partial remission. So I think it's a very nice example and shows you very nicely how these patients benefit from PRT. And this is also one of the reasons that there was so much excitement back in 2017 when this study was published. Now, the patients were followed up, and this is now very exciting data presented actually only a few weeks ago in Chicago at the ASCO 21. And what we see here again are the survival curves. It's now the long-term follow-up. Now, the patients who underwent PRT are in orange compared to the patients who received high dose of octreotide. And all the difference, the area which you see in between the curves here is actually clear-cut survival benefit of the patients who underwent PRT. If we're looking again at the values of the 50% line, the median overall survival here, we see that the PRT arm had 48 months compared to 36 months for the control arm. But, and this for full transparency, was not statistically significant anymore. Now, some of you might be shocked and said, what does it mean? How is this possible? The curves looked so pretty in the interim analysis. And actually, the explanation is actually quite easy to this, because one of the beauties of the initial NETA-1 study was that the patients who showed progression in the high-dose octreotide arm had the opportunity to cross over, to also get access to PRT. And this, of course, when you just imagine that a patient gets access to a very potent treatment, he gets later access to the treatment still, however, works. And this is one of the key explanations why we do not see an overall survival benefit in the long-term follow-up. However, this is not the main reason of the long-term follow-up. The reason of long-term follow-ups usually is to find out how well is such a therapy tolerated by patients. And this is, I think, data which I really want to share with you because I find it absolutely exciting. A lot of people always question radioactive treatment and the potential side effects of this treatment. And one of the things people are worried about are other tumors, so-called secondary malignancies. And the ones people are most afraid of are actually the myelodysplastic syndrome or acute leukemia. And in this long-term follow-up here, again, additional 4 years compared to the primary publication, there were no new cases found of both myelodysplastic syndrome or of acute leukemia in the group of patients investigated in the whole NETTER study, which means not only the arm of patients who underwent treatment, but especially in the arm of patients who underwent included to primary PRT. Another topic which people are always worried about is obviously the kidneys and the potential nephrotoxicity. And as most of you know, we give the PRT treatment in addition to a so-called kidney protection. And in these long-term report, we can now actually see that indeed a significant amount of patients, in this case 40% of the patients, had grade 1 or 2 events, but only very few, in this case 6 out of the 111 patients primary randomized to PRT, had a grade 3 or higher event. So overall, we have to say that this therapy is very, very well tolerated. And coming back to the question, why Lutathera? Why do we talk about Lutathera? And this is actually, for me, the summary slide of this first part. So first of all, Lutathera is a very potent treatment. And the long-term follow-up has shown that indeed the progression-free survival benefit is not only significant, but it even has a value in this case ratio now of even 0.18, which means, again, more than 5 times higher likelihood to experience progression if patients did not receive PRT. And even in the long-term follow-up, when we look at the overall survival, there's a meaningful improvement of the median overall survival of almost a year. You remember 36 compared to 48 months. It's a very safe treatment. So there were no new safety signals during the long-term follow-up, which is very important, especially in regards to nephrotoxicity, but even more secondary malignancies such as MDS and also acute leukemia. And again, emphasizing the issue with the overall survival, that there was no significant benefit found. I just want to quickly state again, this is actually the case in any other phase 3 studies in neuroendocrine tumors so far. And the main reason is on one side that the patients were allowed to cross over, but also the overall long survival, luckily the overall long survival in neuroendocrine patients makes it rather unlikely that you find a significant overall survival benefit in the long-term follow-up. So this is the first part, and I hope I've shown you a little bit why Lutathera is such an exciting treatment and why we should really discuss also a little bit how does Lutathera work. And this slide is a slide I've shown many, many times already because I think it's a very good example to explain what is the thanostic principle. Overall, the principle is quite easy. All we need is to have a very specific target, ideally a target which is only found in the tumor cell. But if not only found in the tumor cell, but predominantly found in the tumor cell. The next step is that we have to identify a very specific ligand binding to this target. And if this is the case, all I need to do is I have to find the linker and connect it to a radionuclide. So now for PRT, this is quite simple. We already all know that the corresponding target is a somatostatin 2 receptor, as seen here. Then the ligands which bind very specifically to the somatostatin 2 receptor are octreotide and octreotide. And all we need now is we have to connect it to the radioactivity. In this case, the linker is a chelator DOTA, and the radionuclide for therapy is lutetium-177. But many of you might have heard or already have directly undergone already a gallium scan, a DOTA scan, often called DOTA scan. And in this case, all which is actually exchanged is that the lutetium-177 is replaced by a gallium-68. So how does it really work that once that the radioactivity is injected into the veins? Well, it's distributed throughout the body, and this radioactivity is going through the body and trying to find the somatostatin 2 receptor on the cell surface. And this, just as an example, as an imagination, is a tumor cell membrane. You see here the different kinds of somatostatin receptors expressed, and the radioactivity then very selectively binds to the receptors, mainly the somatostatin 2 receptor, but in some of the tumors, the ligand also binds to somatostatin 4 and somatostatin 5 receptors. Then, once bound to the receptor, this radioactive peptide complex is taken up into the cell via early endosomes. And then there is a ligand receptor dissociation. The radioactivity in the compound stay in the cell, whereas the receptor actually is recycled, goes back to the cell surface, and is ready to bind new radioactive peptides. I mentioned before that one of the nice things is lutetium-177 can not only be used to treat the tumor, but in this case, there's also a so-called gamma component, a photon component, which allows us to make images afterwards. And this is an example of a patient where we can very nicely see after therapy where did we really deposit the radioactivity on one side. The second thing is we can even measure how much radioactivity we have deposited there. So what it's often called the so-called dosimetry, that we can even calculate how much dose was really delivered to the tumor, how much dose was delivered to the healthy organs. I don't want to irritate you too much with these kind of things, because dosimetry is something which is really exciting, especially for development of new therapies. But the way Lutathera is currently used, it's a fixed dose. Every patient gets the same dose. And overall, again, looking back at the NETA-1 study, the results were absolutely stunning. Now, in the third part, the big question is what comes next? Is this already the end? Or can we expect even some new magic tricks to happen from the field of radioligand therapy? And there are a couple of different things I want to highlight. The first one is actually that there are a number of new studies, even in the post-NETA-1 era. And the first one I want to show to you is actually NETA-2 study. Not really surprising, NETA-2 is from the whole design very similar to NETA-1. The main difference in this case is that this focuses on patients with a higher grade tumor. As you remember, maybe the patients who were investigated in the NETA-1 study, which also includes currently the label of Lutathera, are patients who had a Ki-67 of smaller than 20%. And the NETA-2 study now focuses on so-called higher grade G2 and G3 tumors. And in this case, the Ki-67, which is allowed in the study, is ranging between 15 and 55%. A second thing, which is a little bit different from the NETA-1 study, in this study, patients are also eligible if they are naive to somatostatin analog treatment. And this is kind of from the whole understanding, as you know, the NETA-1 study was offered to patients in second line after they showed progression on cold somatostatin analogs. In contrast, in this case, this is even investigating PRT in a first line scenario. Looking a little bit more on the design of the study, I just want to show you that overall the whole pattern is very similar to what you have seen for NETA-1. Once the patients are screened, they will be randomized. In this case, 222 patients randomized in a 2-to-1 fashion, which means 2 patients will go into the Lutathera arm, 4 cycles, plus 30 milligram of octreotide, the same as for the NETA-1 study, and 1/3 of the patient will go to a high dose of the cold somatostatin, the octreotide. Now, again, and this is very similar to NETA-1, and I think this is very important also when we talk about patients, because if you're lucky, you are randomized to the Lutathera arm, but what do you explain a patient who is randomized to the conventional arm of 60 milligram of octreotide? And I think the very important and good thing is that we can tell patients that if patients show progression in this arm, they are also offered crossover. They will have access to Lutathera and benefit from the treatment, as also shown in NETA-1. I showed you initially that they are octreotide and octreotide, and both of them are different ligands, but they behave very similar. And indeed, there's also a number of studies investigating DOTA-TOC, which is the other of the 2 ligands. And here, just for comparison, and don't worry, I don't want to go with you into details of the slide. It's actually a slide I made for my residents. So we know for all the open studies which patient would fit into potentially into which study. The 2 on the left, NETA-1, NETA-2, have lutetium dotatate as a investigational compound. And the right side, compete and compose, are very similar studies using actually lutetium DOTA-TOC. The main difference is, and again, I don't want to spend too much time, that on the compete and compose studies, they have as comparator arms rather more active treatments, in this case, everolimus, or even in this case, for the higher grade tumors, investigators' choice, including everolimus, FOLFOX, and CAPTEM, whereas on the NETA-1, NETA-2 both had high dose long-acting octreotide. And the second big difference in the studies is that the NETA-1 and compete are the ones which focus on the well-differentiated tumors with a Ki-67 smaller than 20%, whereas NETA-2 and compose are studies which include a Ki-67 from 10 to 55% or from 15 to 55% for the compose studies. Overall, nevertheless, a very similar design and also a very similar kind of compound. So it doesn't really matter if you get DOTA-TATE or DOTA-TOC as long as you get one of those 2. Now, another big hope is obviously using new, even more potent ligands. And one of the things you might have heard before are the somatostatin receptor antagonists, which means the same receptor as a target, but instead of an agonist, we're talking now about antagonists. And this has been around for quite some time. And there's also a compound which has been already in humans. The first data was reported in 2014, back then von Damenwild in Freiburg, who's now in Basel. And what they did, they showed that patients who did not respond anymore to somatostatin receptor agonists underwent treatment with somatostatin antagonists, which again seem to have a more effective, better binding to the somatostatin 2 receptors, and the patients seem to have benefited, as also shown here, from the arrow showing indeed a decrease in tumor size. As you can see, however, this data was published in 2014, so we're now in 2021, and we still do not have approval or even a prospective ongoing phase 3 study potentially aiming for approval. So I still really hope that because this kind of compound has been in different hands, so I really hope that eventually this compound will make it to the clinic, because I still put quite a lot of hope into the higher potency of this treatment compared to the somatostatin receptor agonists. Another potential avenue for the future is obviously combining different kinds of therapies. And even so, we talk about quite early timing here. I just want to highlight different approaches which are currently discussed and partially already in early clinical trials. One of them is combining PRT with so-called radiosensitizing treatments, meaning to potentially increase the impact of the PRT on the tumor cells. A second one, and some of them have been already reported in very small study populations, the combination of PRT with chemotherapy. Then a very nice, interesting approach is obviously the combination with PARP inhibitors. There's also a very early study combining PRT with immunotherapy. One of the ideas is that the radiation delivered by PRT potentially could turn immunological cold tumors into immunological hot tumors, but all this is still in very early stage. And there has been already also been quite interesting studies being reported in using PRT actually in the neoadjuvant setting, where patients are not resectable to make them with PRT resectable. And the main idea is here using PRT to increase the likelihood of really curing patients. Another idea and hope is obviously to dig into the vast amount of different radionuclides. And one of the keywords everyone is currently hoping for is obviously the use of alpha emitters. I mentioned before that lutetium dotatate uses a beta compound for the therapeutic impact. And this is a study very early on published in India, using instead an alpha emitter, in this case actinium-225. And I just want to quickly highlight and also show you that there is hope, because here even patients who did not respond to lutetium dotatate or only showed stable disease, they were treated then afterwards in an experimental setting with actinium-225 dotatate. And indeed, the number of patients who all of a sudden showed partial response was quite high. The objective response rate, 63%, is pretty impressive. But again, these are only, it's a very early stage, and this will still take a number of years and also a number of phase 3 studies to really test if this is ready for prime time. In summary, I want to thank you very much for your attention. I hope I have shown you a little bit what is the global perspective of Lutathera, why is Lutathera so exciting, how does Lutathera work, and more importantly, that this is not the end. We still work very hard together, and there we also need your support to find even better and more effective ways to treat neuroendocrine tumors. Thank you very much.
We're here with Rebecca Miro, who's a nurse navigator for UCSF, who works with patients and navigates them through the PRT experience at the University of California, San Francisco. Rebecca has spoken to the NorCal Carcinet group many times about what to expect during your PRT treatment, and our group has really benefited from her knowledge and wanted to share it with the rest of the community. So really wanted to thank you for all the work you've done with us, and the floor is yours, and we look forward to what you have to say today.
Thank you. Thank you all so much for having me. I'm so excited to be a part of this and this global event that we're embarking on today. So thank you again, and I look forward to sharing my knowledge. So my name is Rebecca. I am a nurse navigator and I care for PRRT patients at UCSF in San Francisco, and just wanted to share some information to help understand what's happening before, during, and after PRRT therapy. Of course, this is going to be most specific to PRRT at UCSF or in the United States. There may be some differences with other facilities or different areas, but just wanted to give that as well. So I know that we've received a lot of information in regards to what PRRT is and what it does, but just as a quick overview, the peptides are those small molecules in the therapy which are similar to somatostatin, which we're familiar with in somatostatin analogs, which many patients do receive. The receptor is something that is the specific target that peptide attaches to, and we like to think of the somatostatin receptors in correlation with DOTA scans that many of you are familiar with, or DOTA Tate scans. And the nucleide is going to be that radiation avenue to get the radiation into the cell. I like to refer to it to patients as kind of bringing in your popcorn into the movies or your candy. That is the way that we kind of sneak that radiation into those tumor cells so that we can treat them throughout the body. So I wanted to start with before PRRT, just a kind of regroup of what to expect and to help to plan. My role as a nurse navigator starts here as far as collecting records, reviewing information, and just kind of setting the stage for what to expect over the next couple of months. That does include making sure that we review all of your records and of course confirm that you would qualify for this treatment. We would defer to the physicians that are caring for you and care teams as far as the correct order of treatments that you would be receiving. But if you do live far away from facilities, just wanted to make it known, especially through this group that we have received information from today, that there aren't many facilities that do offer PRRT. So there are many times where patients might travel a couple of hours, whether it's driving or flying. So just make sure that no matter which facility you're going to be receiving your care at, you're speaking with your team and having a close communication with someone who's going to assist with coordinating. As far as tests that are going to be necessary before starting your treatment, oftentimes we will repeat certain lab values or diagnostic imaging, especially if it's been a little bit of time since you've had a CT or MRI, just to have a baseline or repeat baseline before going ahead with treatment so that we can use that as a comparison going ahead. And as far as who will help with coordinating treatments, I am the PRRT nurse navigator at UCSF. I would just make sure that wherever you're going to be receiving care, that you kind of understand what the contact points are within your oncology and nuclear medicine teams and know who to reach out to if you have any questions when moving ahead with everything. A lot of questions that are oftentimes asked are kind of what to expect in regards to preparation for the day. So I just wanted to include some information. Of course, this will be deferred to your specific facility, but typically speaking, are there any dietary restrictions before each treatment? No, I would say that we also would not want patients to vary from their regular daily routines or diets. I tell patients to drink their usual coffee and have their usual breakfast, especially because patients are oftentimes grappling with some GI symptoms. Of course, we don't want them to try new foods or different foods immediately before treatment, just to tease out if they do become nauseous or aren't feeling very well afterwards. So just reducing the variables. But I would say, for the most part, no dietary restrictions, and we would want patients to stay well hydrated. As far as walking, some patients do need a little bit of extra assistance. It's just something to keep in mind, especially when having an IV pole in the room. So that's one of the things that I or your nurse navigator or care coordinator would be speaking to, just to make sure that we best prepare for your visit if you do need any mobility assistance. As far as daily medications, Your team would be describing what is going to be taken after treatment. Typically, we don't recommend stopping any medications beforehand, but of course, just defer to your local team. Of course, many patients are receiving somatostatin analogs, which are usually given every 4 weeks. So that would not be a problem. We typically just kind of factor that into the scheduling of the treatment itself and just make sure that the timelines of both are cohesive. In regards to what a typical schedule looks like through PRRT, and this is typically speaking, of course, there could be variations for each specific patient or facility, but usually we will give PRRT, and this is the IV, not the intra-arterial. We do give it 4 times, which are about 8 weeks apart. In between that time is when we would be repeating blood tests and sometimes imaging, but the next slide will kind of outline what a typical schedule would look like and what I would prepare for a patient before we get started with everything. Okay, so what does a typical PRRT schedule look like? I refer to them as a planning blueprint, which is something that I'll create for a patient before we get started, just so that they kind of know what the next couple of months are going to hold as far as appointments. Oftentimes patients are receiving care with us for their treatments, but might also have a local oncologist. So just kind of laying out what to expect and know what is coming down the pipeline. So the image on the left-hand side is just showing what to expect as far as a visual. So there are 4 treatments that will be given total, typically speaking. In between that time is when we would want to check labs. Oftentimes we'll recheck diagnostic imaging after both the second and the 4th treatment. Reason being that you would be about halfway through with your cycle if it's after number 2, and if it'll be about 4 weeks after your 4th one, then it would be reassessing imaging after completion of all of your PRRT. The right-hand side is showing a blueprint example that I had given recently, and I think really does kind of display what a typical blueprint would consist of. So 4 boxes for 4 cycles. Each of the treatments for our facility is typically paired with a SPECT scan, which is a next day scan that's going to occur the day after each of your PRRT treatments to assess the uptake of therapy. So each of these does consist of the PRRT, the SPECT scan, which is the next day. Oftentimes, our patients receive somatostatin analogs every 4 weeks, so I've included that as well. Our facility will have the patient see our nurse practitioner as kind of a 1-week check-in about 1 week after their first PRRT, just to kind of review symptoms, even though I'll be speaking with them anyway, just for a formal provider check-in. And then after each treatment, typically about 4 weeks after, sooner if necessary, is when we would be rechecking labs. So I would fill this in with all of the dates of kind of what to expect and just kind of reassure my patients you don't have to check your calendar every day. I'm looking at these as well for all of our patients and providing reminders about 1 or 2 weeks before things are due. So typically after, as I had mentioned, the 2nd and the 4th is when we might want to repeat diagnostic imaging. Oftentimes that's a CT scan or an MRI. It depends on the patient and the best form of imaging surveillance. So you would just kind of refer with your team as far as how they would like to follow you throughout and kind of compare the imaging throughout the course of treatment. Okay, so one of the points that I had wanted to dive in a little deeper on when we did the NorCal Carcinet talk is radiation safety precautions. I know that this is a major point that patients have questions about and want to know more about. Of course, we would want you to speak with your specific facility and their radiation safety officer as far as specific parameters and timelines for these things. But generally, these are the main take-home points to kind of take home with you after each treatment. So the way that I refer to PRRT is kind of like being near an outdoor heater, if you've been to a restaurant with an outdoor heater. So the only way that people around you would get warm is if they're very close to you for a long period of time. So for that reason, if we're sharing the bed with a spouse or loved one for 8 or 10 hours at night, that is a lot of time to be very close to that person. So we wouldn't want that to occur within the days following each of your treatments, because it could increase the amount of radiation exposure that that person would be exposed to throughout their lifetime. So the first thing that I review with patients when kind of planning ahead for each of these is just ask, do you sleep alone at night? Or if you share your bed with someone else, we do recommend making sure that you have some separate accommodations for a couple of nights, just to make sure that you're not too close for too long. The second way that anybody would have exposure to the radiation that is being absorbed in your system is going to be bodily fluids. So for that reason, we do ask for even men to sit down when they're urinating following treatment. We have a little lap cover as well as shoe covers that'll be worn during the treatment itself. And the main purpose of that is we don't want anyone to come in contact with your bodily fluids, especially the urine during the time of your first treatment, since it will contain the most radiation in that first void. So the reason that we ask for men to sit down is it reduces the risk of splashing. And then we also just ask for patients to really wash their hands well if they're changing any incontinence products, or just after using the restroom in general, since there will be some radiation in that urine. Most patients, I would say, can return to work the week following each of their treatments. Of course, it depends on your type of work. If you work very closely with young women or young children, pregnant women, then we might recommend for you to wait a little bit longer if you're going to be spending a longer duration of time with those people. If you have maybe a more physically active job and you're experiencing some fatigue following treatment, then we might recommend waiting a little bit longer. But from a radiation safety perspective, we usually say that the following week is okay to return to work. And as I had mentioned before, of course, this is going to have a wide audience of patients receiving this therapy at different places and in different countries. So definitely refer to your radiation safety officer as far as the more specific timelines and parameters of these things. But these are just kind of good things to keep in mind as far as planning ahead for what to expect. Okay, so what happens during the treatment itself? There's so much lead up to what to expect, what are the appointments going to be laid out as, but what happens when you get there? So the first thing that's going to happen is usually one of your team members will, of course, meet you at the front, bring you back and show you your space for the day. Just given the nature of this treatment, you will have your own private room and restroom because of the radiation safety implications. Of course, we would be starting to obtain your vital signs, make sure that clinically you're stable, obtain IV access, or if you have a port or peripheral line. The first fluids that are started are typically saline, and of course this might also vary based on the facility, but the way that we proceed at UCSF is just by starting saline as a basal fluids that you'll be receiving for hydration throughout the appointment. The next infusion that'll be started and through the same IV line is going to be an amino acid solution. So the way that I explain this is it protects the kidneys. We want to make sure that as the excess radiation exits the body through the urine and makes a pit stop in the kidneys, we want to make sure that your kidneys are protected. So this is kind of that extra coating or extra precaution to give your body that safety for the kidneys to help prevent fluctuations in lab values or clinical changes. We do like for the amino acids to be running for at least 30 minutes before starting the Lutathera or PRRT treatment itself, just to make sure that your body has already received 30 minutes of that nourishment from the amino acids. When the nuclear medicine physician will stop by the morning of your treatment, that is when you would be reviewing any remaining questions, concerns, signing consent, reviewing some of the radiation safety information as well, and more specifically, some facilities have a form that you might sign, and I would recommend that if they do give you a radiation safety form, that you do keep it in your wallet, especially if you are going to be traveling within a couple of months following treatment, just so that you don't get hung up at airport security or anything like that. The actual treatment itself will be given through the same IV line. There won't be a separate line, at least at our facility, and it only goes over about 30 minutes. So although you're kind of stuck with us for the 4 hours that the amino acid solution is running, you will have only about 30 minutes of receiving the drug itself. I did make sure to put in there that it's not painful. Many patients ask if they're going to feel anything different immediately following receiving the dose. You won't feel anything different when it's being infused. Of course, we'll be checking your vital signs and reviewing any side effects or symptoms that you may have, and can give you medications as necessary for that. But during the actual infusion itself, we wouldn't notice anything much different since it's just going through the same line. Radiation safety precautions following the dose is, as I had mentioned, those lap covers when you're urinating, just to prevent any extra splashing. We also recommend that patients flush the toilet twice after using it for the first couple of days following each treatment, especially if they do use a shared restroom. And the additional radiation safety precautions would also include the shoe coverings that we give during the appointments themselves, and then sleeping separately from family members, etc. The last thing before you head out would be for us to review your discharge summary. So at UCSF, I'm the person that provides your discharge summary that kind of lists out all of the symptoms to keep an eye out for, what the reporting instructions are based on those symptoms, what are your upcoming appointments, and then for any needs that you have, who to contact and how to get a hold of them. These are pictures that I actually took this morning around 6:30, and just wanted to kind of show, of course, different facilities are going to have their setup a little bit differently, but one of the things that I arrange as a part of my job is environmental health and safety and radiation safety, coming and setting up these rooms the night before each of these treatments, as well as decontaminating the room appropriately after each of the treatments has taken place. So the left-hand side picture is our restroom. It has some absorbent pads around and also a cover on the toilet seat. For the lap covers or any incontinence products or shoe covers, the bin that has the emblem for the biohazard radioactive is where you would put that. And the center picture is of the bed, which is adjustable, and there's coverings throughout and around it. And we do use linens on top of that as well. And the picture on the right-hand side is just showing some collection containers which are present in the room as well. There's a Sharps biohazard, and also for anything that's come in contact with bodily fluids, there's a Lucite container with a special bag in there to make sure the IV catheter or anything else that might have touched bodily fluids is kept safe. The radiation safety officer and environmental health and safety do round on these rooms and do decontaminate them before any patients or other patients might be using the same room the following day. So after discharge, things to keep in mind, and this would all be included in your discharge summary as well, but just so that you have an idea of kind of what to expect. I always tell patients that in the days following treatment, you might just be a little bit tired, maybe not as hungry as usual. So if you're not as hungry, just try to eat a little something throughout the day to keep your stomach settled. The last thing that we would want is maybe being too tired to eat and then skipping a couple of meals and then feeling nauseous or lightheaded because of that. So usually I just tell patients, of course, every patient is different, but I would say the first couple of days after, especially your first PRRT, just make sure that you don't have any big plans, anything that's too strenuous or active. I would make sure that any errands that you need to run are taken care of beforehand, just so that you can relax and kind of focus on how you're feeling Sometimes patients do notice some fluctuations in GI habits, so you might have some more or less diarrhea than usual, sometimes some abdominal cramping or pain. Anything that's mild and kind of comes and goes is within the realm of what we would typically expect within the days following each treatment. And of course, some changes in blood values do occur throughout the treatment, so that is why we are going to be checking throughout, in between each of the cycles and thereafter. Although rare, carcinoid crisis can be the most severe side effect of PRRT and would occur within 24 to 48 hours of the therapy. Of course, for any time that a patient is feeling chest pain, shortness of breath, feels like they're going to faint, if there's severe flushing, sweating, we would want them to present to the emergency room. So same thing with the carcinoid crisis. If you're starting to feel like your flushing is very severe, you're very lightheaded, experiencing palpitations, maybe are vomiting or having more severe diarrhea, then we would want you to report to your nearest emergency room. And in rare cases, there are sustained changes to lab values, bowel obstructions, or other conditions that have been reported in the years following PRRT therapy. Your team will review with you if they think that you might be at a slightly higher risk for developing any of those, and there are some medications which can be administered to kind of help deter that. Contact your team for any questions, concerns, moderate symptom changes. I always tell patients if it's within the realm of kind of a mild symptom or something like feeling very tired, maybe not as much energy as usual, not as hungry as usual, or a little bit nauseous, that's kind of in the realm of what we would expect within about a week following each treatment. But anything more severe or sustained, we would want you to go to your local emergency room or call 911. And following your treatment, it is important to stay well hydrated. We want you to make sure that you're not becoming lightheaded or dizzy, that you're continuing to maintain the same nutrition. That is definitely something that is reviewed during your discharge instructions, as well as just making sure that you have some planned periods of rest. As I mentioned before, I usually tell patients to just make sure that they handle any errands or make sure that they don't have anything too arduous coming up in the few days following each of your treatments so that you can rest. We'll be monitoring your blood work throughout, usually about 2 or 4 weeks after each treatment, to assess for any changes. So we just ask that patients, of course, continue to monitor themselves, let us know if there's any signs of infection, bleeding, or if their fatigue just really seems to be keeping them in bed. We also provide a form that specifically contains the radiation safety recommendations, and your facility will likely have something very similar or the same. As I had mentioned before, I recommend that patients keep that in their wallet for about 2 months after treatment, just in case they're traveling and run into any concerns. And then for any additional questions that you might have in regards to radiation safety symptoms, if you're just get back to your hotel or home and are not feeling quite like yourself for a couple of days, we would definitely want you to give our teams a call. So what happens next? After completion of your PRRT, the planning is not concluded. We'll make sure that your navigator is assisting with your future care and helping to outline when your next treatments or labs are. So basically, we'll create a very similar care coordination plan to make sure that we're monitoring your symptoms, your labs, follow up appropriately with your local providers or your facility that's providing the PRRT. So just kind of making sure that you have a list of what to expect over the following couple of months now that you've completed therapy, and making sure that you maintain the connections and care with other physicians that maybe you haven't seen as frequently throughout your active treatment. And as far as contact information, please definitely give us a call or send me an email if you have any specific questions, are looking to receive treatment, have any family members that might be receiving treatment, anything, please definitely contact me. Any questions following this or things that maybe I can elaborate on a little bit more with you personally. And if you're receiving your care outside of UCSF, just make sure that you speak with your team to best understand the main points of contact of who's going to be helping you as far as your care coordination before, during, and after PRRT, These are just pictures of our neuroendocrine team at UCSF get together with the dogs. So just wanted to include that in here as well. But just want to thank you all so much for allowing me to review this information and participate in this care. And yes, please definitely reach out to me if you have any questions.
Well, we've come to our last session of the Patient Education Day before we go to our Q&A session. And I'm pleased to have with me Dr. Simran Singh from the Sunnybrook Cancer Center at the University of Toronto, kind of completing our global trip here. We started in Singapore, we've gone through learning imaging at UCSF and on to learning more about PRT from our colleague in Germany. And now, to really close off the afternoon, wanted to talk to Dr. Simran Singh about where nuclear medicine therapy fits in with patient care for neuroendocrine tumor patients and where we're going in the future. And I was really quite fortunate to work with Dr. Singh at the clinical trials planning meeting, where one of the things we were addressing is, clinical trials in the era of PRT, and I know Dr. Singh will talk about that. But without much further ado, Simran, the floor is yours, and I look forward to your talk.
Thank you, Josh. I really appreciate the invitation and the ability to talk to everyone today. As you mentioned, I'm a medical oncologist in Toronto, Canada. And I'm going to talk to you today about PRT in the treatment of NETs and also about the future of clinical trials. I think it's very important for patients to be aware of clinical trials and what the clinical trials are coming up, and the idea that they may want to consider participating in clinical trials, or they may want to give input into what kind of clinical trials we should have in NETs moving forward that are important to patients and are important to what matters to patients. These are my disclosures. I'm going to talk today from my perspective, which is out of a medical oncologist. So I give what we call systemic therapy here, which means chemotherapy, pills, medication. So when I see PRT, I look at it through the lens that I've been trained at, the lens that I see from my systemic therapy standpoint. And so this might be slightly different in that viewpoints you might get from someone who sees this from a nuclear medicine point of view, for example. So this PRT is a really interesting type of therapy. So peptide radioreceptor therapy, what should we consider it? Is this internal radiation therapy? Is this radiation therapy that we're delivering internally? Is this what we call systemic radiation therapy? Is it a form of systemic therapy, much like chemotherapy? It goes into your veins. Or is this, radiopharmaceutical therapy? Is this a completely different category of its own? I'm not sure I could say for sure what this is. It's probably a combination of all. But what I will say is that this is getting to a point where we're moving towards true personalized medicine in neuroendocrine cancer. And by personalized medicine, I mean the right treatment for the right patient at the right time. So as a medical oncologist, what goes through my head when I'm sitting with my patients in clinic and we're discussing what the options are? What are the discussions me and my patients are having about their treatment options? First one is, when do I use systemic therapy or traditional therapy like chemotherapy or pills or targeted therapy versus PRT? And specifically, what sequence? Should I use systemic therapy first and then PRT, vice versa? And is there certain patients that benefit from one approach versus the other? Is there a promise for combination therapy with PRT? So if I give PRT along with one of the medications that a medical oncologist would normally give, does that work? Is it safe? Is it better? Is it worse? And how about after PRT? What has the PRT done to the body and done to the disease that I can give the patient the most effective therapy with the least effect on their quality of life? So to start off with, let's talk about, when do I use systemic therapy versus PRT? And I'll say right now, I don't have a lot of answers, but I certainly have a lot of questions. And I'm hoping to discuss this with you so that we can together in the future work with patients, physicians, healthcare providers, all of us together can try to answer some of these questions so that we can offer the best treatments. So I was fortunate to work with this group here. When PRT became available in the United States primarily, but now also in Canada, we worked together as a group to try to decide to say, where does PRT fit in? What was our North American perspective? And I'm glad that we took a larger North American perspective. So when we sort of looked at PRT, NANETS and SNMMI partnered to come up with these consensus statement guidelines. And so what did we come up with as a group? And this was a group of medical oncologists and nuclear medicine doctors, a wide variety of different types of people, including patients as well. We said that basically after people have their first line somatostatin analogs, i.e. first line injections, they should be considered for PRT. For patients who have midgut or small bowel tumors, if they're secreting hormones, really we should be considering PRT as soon as they progress after a somatostatin analog such as lanreotide or octreotide. If they don't have secretion of hormones, we really want to look at an individualized situation. PRT may involve travel. Some people may prefer a daily pill. Some people may not prefer the side effects of everolimus. So that really has to be individualized. And a lot of that we're going to talk about has to do with discussion with patients together. When it came to pancreatic neuroendocrine tumor, we realized that we have more options, thankfully, but we again need to find the right treatment for the right patient at the right time. And so further research is needed to understand the sequencing of how we should use PRT when it comes to pancreatic neuroendocrine tumors. These are the European guidelines, and certainly I'm not going to go through these in any detail. What I do want to sort of convey to people is how confusing this can be and why it's so important to have an individualized approach when working with patients together to try to understand what treatment is right for the patients. Here we see that somatostatin analogs may be an option. Generally, those are our first line, but after that, we may decide to use everolimus, we may decide to use PRT, we may decide to use chemotherapy. And again, a lot of this depends not only on the characteristics of the disease, but on the characteristics, the preferences, and the lifestyle of the patient. So what about everolimus? How does that fit in when we compare to PRT? So as a background, this was the RADIANT-4 trial, which was done. It looked at patients who had lung or small bowel neuroendocrine tumors. Patients on the trial either received everolimus or a placebo. The primary endpoint was something called progression-free survival. For those of you who aren't aware, that really is an endpoint that means how long could we keep people alive and not have the tumor growing? And so that is what we call progression-free survival. And this was the endpoint. What we did find is that patients who received everolimus did much better than patients who did not. We were able to hold the disease or keep it stable for an average of 11 months versus not even 4 months on the placebo arm. So what we call a hazard ratio of 0.48, that means there's a 52% chance of a reduction in the risk of progression or death if you're on everolimus. So clearly, everolimus works. Then we had this other study that came out soon afterwards that was published in the New England Journal of Medicine, which is one of the most, if not the most prestigious medical journal out there. This was called the NETTER-1 trial. And this was the first trial that we had that gave us evidence about PRRT. These are patients who had small bowel neuroendocrine cancers that had progressed after our standard first-line therapy, which is somatostatin analogs, and they were then randomized to either receive PRRT or to receive a higher dose of somatostatin analogs. In this situation, it was 60 milligrams of octreotide. When we look at the results of this trial, they were good. You can see here, if you look on that top corner, green is the patients who received PRT, black is the patients who received only the increased dose of somatostatin analogs, and you can see very clearly just looking at it that there is a difference both in stopping the progression of the cancer, but also in helping people survive longer. We found that it worked in a variety of patients and that it was one of the rare treatments in neuroendocrine tumors that could actually potentially have an opportunity to shrink the tumor. Recently, data was presented looking at the overall survival difference, and it did appear that when we adjusted for some of the differences between them, that people were going to live longer being on PRT. Now, because there's something called crossover on these trials, which means that people, in fact, who had the treatment, didn't get the treatment, got the treatment, it's hard to display this in the trials, but it does look like this is a very effective treatment in controlling this cancer. And what about when we get to pancreatic neuroendocrine tumors? Well, the picture isn't as clear there. What we do know when it comes to pancreatic neuroendocrine tumors, we have some very small studies. Most of them are what we call retrospective studies, which means we look back at records to try to see how effective they were. This isn't as good data as what I just showed you. When we do things prospectively plan ahead to look at these outcomes, it's always stronger data. There are 2 trials underway right now that are going to be important. One is called the COMPETE trial, which is being done across the world, including the United States, which is looking at everolimus versus PRT direct in pancreatic neuroendocrine tumors. The second is a trial being done in Europe called the SECATOR trial, which is looking at chemotherapy versus PRT. So I do anticipate that some of these questions we still have about what's the best treatment for pancreatic neuroendocrine tumors, we might not get the final answer, but we will certainly get a lot more information from these 2 trials. What are the other options for pancreatic neuroendocrine tumors? Well, Pamela Kuntz, who was Stanford at the time but is now at Yale, did this excellent trial that looked at patients who had pancreatic neuroendocrine tumors. And it was a trial looking at temozolomide and capecitabine, so oral chemotherapy. Again, patients, we looked at what we call progression-free survival, which is preventing the tumor from growing. And these were the results. And what it really showed is this combination of temozolomide and capecitabine was quite effective at holding back the tumor from growing for a period of time, in this case, a median time of 22.7 months. So again, this became an important part of our arsenal to treat neuroendocrine tumors. And we know that some patients who need a quick response, chemotherapy may be the right option for them. So this year at ASCO, we also had the results of what we call the NETTER-R study. Now, again, this was a good collaboration, but this is still retrospective data, which means we look backwards. But I have to say this was a great collaboration internationally to look back at the results of 110 patients who had pancreatic neuroendocrine tumor that was treated with PRRT. And what we found here was a good PFS, progression-free survival, of 24 months, much aligned with what we just saw in the chemotherapy trial that I just showed you. Again, this isn't the best data and not all the data we'd want. We want prospective clinical trials for that. But looking back at the data we have, there does look to be promise for PRT in pancreatic neuroendocrine tumor patients. How about lung neuroendocrine tumor patients? This is probably where we have the least amount of data. The numbers are very small. We have a small amount of data in terms of lung neuroendocrine tumor patients looking back. We really do need some more data on this. We don't know if PRT can be an option after patients who get everolimus or instead of everolimus. We also don't know if patients who have neuroendocrine tumors of the lung potentially have the right receptors to make this type of treatment work. The good news is there's a trial about to be launched by Tom Hope and Suki Pata. Tom Hope is at UCSF and Suki Pata is at City of Hope. And they are, have approval and are about to launch a trial looking at this very question. In lung neuroendocrine tumors, is PRT better than everolimus? And this is going to be a very important trial because it might change the way that we treat lung neuroendocrine tumors. What about in what we call high-grade disease or grade 3 disease? Well, there's a trial underway right now. It's an international trial called the NETTER-2 trial. If you remember, I showed you the results of the NETTER-1 trial. This is the follow-up trial called the NETTER-2 trial. High-grade 3 neuroendocrine tumor patients are those patients that have a bit more aggressive neuroendocrine cancer. This trial is going to look at upfront, right away, starting with PRRT for these slightly more aggressive cancers versus a higher dose of somatostatin analogs. So as I mentioned before, generally we use somatostatin analogs first, and then after things progress, we move to PRRT. In this trial, for these slightly higher risk patients, we're examining if upfront PRRT or starting with PRRT right from the beginning would be of benefit to patients. And this trial is underway internationally right now in many countries around the world. Other questions that I was mentioning is what are the role of combination therapy? There is a trial that came out of Australia looking at PRT plus chemotherapy. Again, this looked at both whether it was effective at stopping the tumor, but also what was the toxicity. Whenever we're talking about cancer therapy, we really want to balance 2 things. We want to balance, is this an effective therapy, but also what impact does it have on patients' life? And where does that balance fit? Now, that may be different for different patients, but overall, we want to get a sense of what's the give and take in a therapy like this. The results of the study, this was a small study, slightly less than 50 patients here, but what we did see is from an efficacy point of view, it was fairly similar. Both PRT alone or PRT plus chemotherapy, the efficacy was similar, but what we did see was a fair amount of toxicity in the combination of chemotherapy plus PRT. We had more toxicity for sure. So really that leans me towards thinking in most situations, I wouldn't advocate using chemotherapy and PRT at the same time, because we may be adding a lot more toxicity and decreasing patients' quality of life without really helping them live better or live longer. The other questions that we need to move forward is immunotherapy or checkpoint inhibition. What if we combine it with PRT? Is there a benefit? And what about what we call poorly differentiated or the very high-grade neuroendocrine tumors? Is there a role for PRT there beyond the traditional role of chemotherapy, which we use now? As you're probably understanding, what we want to do is have a patient-centered approach where each patient, we approach things based on the patient rather than on algorithms or rather than based on a predefined map, because people are different and their individual circumstances are different. There is something called a NET test, which is a blood test, what we call a liquid biopsy, that can look at the genes in the blood and maybe give us some clue to see if there's better patients that might respond better to PRT than others. And this is what we call a predictive tool. There's another tool being developed by my colleagues in Australia called a NET PET score. This looks at both what we would call a SPECT scan or a gallium-68 scan and a traditional FDG PET, and compare the uptake on these to classify patients to help predict who will respond to PRT and who won't. So again, both these are measures to help predict who's going to respond to PRT to be able to offer a more patient-centered model. Other predictive factors, clinical factors like we talked about, tumor location, lung versus others, what's the extent of the tumor, the expression of the receptors that's needed to bind to the PRT, as I was mentioning, and then some more new and exciting stuff, like what about molecular profiling? Can we individualize people according to their genes to be able to understand who's going to respond a bit better to what treatment? What about the rate of the tumor growth? Are tumors that are growing faster or slower? Do some of them respond better? And then there's new things coming up, things like radiomics, where we look at using artificial intelligence, look at CT scans and radiological images to help predict more about the tumor than we can tell currently. So exciting stuff, and hopefully, again, a model where we can design the treatment around the patient. And finally, talk to you about what trials do we have currently. So I'm part of, as Josh had mentioned, the National Clinical Trials Network, which is the NCTN, and we have neuroendocrine trials that we're doing across North America. Right now, we have some open trials. We had a trial looking at chemotherapies in what we call the grade 3 neuroendocrine tumors. That's closed, and we're waiting the final results on that. We do have a trial running now across many centers across the United States, looking at pancreatic neuroendocrine tumors as well as small bowel and lung, looking at a new agent called cabozantinib that has been shown to be useful in other cancers as well. Looking at that to see if that's useful in neuroendocrine tumor patients, called a CABINET trial. And then in pheocytochromas, we also have trials looking at that as well. That's just starting now. We have some trials that are going to be opening very soon. One is the LungNet trial that looks at PRT versus everolimus. We have a trial that's going to be open soon looking at poorly differentiated neuroendocrine cancers, or these very aggressive ones, to see if they benefit by adding immunotherapy after chemotherapy. We have a very exciting trial looking at adjuvant therapy. So for those patients who've had their pancreatic neuroendocrine tumors resected, can we give them preventative chemotherapy to prevent it from coming back? And then we have a new trial in pancreatic neuroendocrine tumors that's going to look head-to-head at the role of PRT versus the oral chemotherapy that I talked to you about. And this was going to be an important trial because it's going to give us head-to-head information about which treatment is better. I'm proud to say we have a good landscape of trials right across pancreatic, small bowel, lung net, high-grade net to be able to explore. As Josh had said, we had a meeting this year, about a once-in-a-decade meeting with the National Cancer Institute, something called the Clinical Trials Planning Meeting. And this was really a great opportunity to bring together virtually, due to the pandemic, worldwide, a group of people who are interested in neuroendocrine tumors, basic scientists, different type of clinicians, patients, researchers, administrators, bring them all together and have a discussion about how do we want to work together to plan clinical trials in this new era of PRT. Some of the major areas that came across that we thought were really important to look at would be, what about retreatment with PRT? Now, this is something I'm very interested in. We know right now that we have very little data on retreatment, but clinically it makes sense. If people have done well on PRT once and they have a good period of time where it stops the cancer, should we do PRT again? Is it efficacious? Is it safe? Is it patient friendly? So we want to look at that. Also, the role of immunotherapy in PRT. Unfortunately, we haven't seen big changes in immunotherapy in neuroendocrine cancers, and I certainly think that's something we want to look at moving forward. What about combination therapy with PRT? I mentioned the Australian study that showed some toxicity of chemo with PRT. What about other things that damage the DNA? Can we do like a 1-2 punch with chemotherapy? What we call liver-directed therapy. What is the role of PRT in patients who have a lot of cancer in their liver? And that happens in neuroendocrine cancer. People may be aware of things like embolization or radiation. And what about those people where PRT doesn't work? What are the options? Why doesn't it work? And is there something we can do to make it work? Is there other therapies or other interventions we can do? Can we increase the amount of receptors? Can we do other therapies to make it work better? So I think these are all really important concepts, and these are things that we're going to be looking at over the next decade or so. So with that, I'll conclude. This is a picture of the Toronto skyline at night, and I'd like to thank everybody for inviting me today.
Well, thank you, Dr. Singh. That was really excellent information of how PRT fits into the treatment of NETs and the futures, some of the futures of the clinical trials. A couple of reminders. This webinar is being recorded and will be made available to those of you who registered or at the SNMMI YouTube channel. We also may not get to all the questions today, but we'll try. And the answers here should be discussed with your medical team. And now I'd like to, since most of you filled out this survey, I'd like to bring up the survey and the panelists who could join us today live. And we have Dr. Herman, Dr. Long-Heath, and Dr. Singh. I will probably call you by your first names because I'm so used to calling you by your first names during this, but know that I know you're all doctors and we're all friends as well. I wanted to bring up the survey. We had a lot of people who are here, and Dr. Herman, this may not be true in Germany and Dr. Singh in Canada, but I know, Courtney, you and I have talked about this. We now have reporting almost immediately or within a couple hours after you've taken a scan. And it looks like the majority, great majority of our patients like that. Is this any surprise to you that number is so high?
Yes, this is definitely a surprise. I alluded to this a little bit in my talk, but there does seem to be sort of a disconnect between what I'm hearing locally from some patients at my institution and results like this. I've gotten a lot of sort of negative feedback about this change. Again, I think a lot of patients who weren't aware of this happening, they get a notification on their phone, hey, you have a new test result, and they open it, and you may not have had a chance to sort of get the contextual information on this. And a lot of times they end up being able to view the imaging report sooner than the doctor that ordered it is able to see it. So they see it before their oncologist sees it. And that has definitely resulted in some difficult interactions, especially if the report's not written in a way that's super clear. It can definitely cause some stress on all sides. But, ultimately, I think it's something that everybody will start to adapt to. And clearly there's demand for this. And I think it makes sense. I think patients have a right to their own information.
So this one's been interesting, and Ken, I'll bring you in on this as well. The number of scans you're receiving, and this is predominantly from neuroendocrine tumor patients, and you look at this, and there's about an equal number about the number of concerns about scans. We've done other surveys like this, that there's about a third of people who are trying to track the amount of energy they've received from all the scans. Does this surprise you in any way? And what are the challenges here in thinking about, scanning energy versus what they might be getting from treatment or the risk of it?
It is a very common question, and we always try to put this into perspective. That obviously the situation is different if someone is, let's say, 18, healthy, and wants to become pregnant, and from someone who is older, has a tumor, and despite having a very good prognosis, still most in the cases having like a disease which is more or less in a, let's say, not curative setting. And that's why we always try to tell them that obviously every time we really decide if it makes sense to, for example, do like a full-blown contrast CT, including the PET, or if sometimes it's really just good enough and wait on the other side, you know. But nevertheless, and I think the most important thing is that the patients, when we think that the patients benefit, that we really expect an impact on the treatment decision, then I think this kind of additional radiation is absolutely justified. Number one. Number two is one treatment cycle, obviously, or even 4 treatment cycles, is a significantly higher amount of radiation than, for example, a PET scan. And there we talk easily about 10, 15, 20, 30, 40 fold of difference. So that's why we are usually a little bit, let's say, especially as doctors in nuclear medicine, we are more relaxed about the radiation associated with the scanning. But it's a very common
and I think
question.
that's true. We're more relaxed. And Simran, I'll bring you into this to kind of complete the global tour we're taking here for the moment. When you prescribe or when you suggest or recommend that a patient gets imaged, do you explain to them the safety, or do you assume that that's going to happen with the with either nuclear medicine or the radiology department?
It's a really good question. I would say previously I probably did not spend a lot of time talking about safety, but I think as we moved to this new world of radiopharmaceuticals, and we're starting to talk a little bit more about radiation, our concern has been for our patients. I'm actually not surprised with this result, and I think it's changed behavior a little bit to increase the idea of safety. It includes a number of scans, but also radiopharmaceuticals, and to reassure people, just as Dr. Herman was saying, about the safety of the scans and why it's so important. I think in most of the discussions I have with my patients, I think when they understand information is important, how it's going to help impact their care, it really helps a lot better that in moving forward with the number of scans that they are doing.
So just an FYI for those of you, we are doing this live, and Simran is actually joining us from his vacation up in a cabin. So we might get some choppy audio from time to time. We might switch to a picture from time to time and let his voice carry. But we're so grateful that all of you can join us from, and Ken, I know you were at a different conference earlier today. As well. So we are doing this live, and stuff happens live, which is really interesting. Talking about being live, looking at, it seems that we're all getting a little bit tired of the flat earth, and that we're interested in being back in person again. Any surprises there for you, Ken or Courtney or Simran?
And I feel the same. I'm very happy to see the patients live. It's much nicer. Obviously, the telemedicine was a perfect tool, better than not seeing them. But and now that we are back to having the opportunity to see them live, I think this is absolutely rewarding for both sides.
I don't think that that a year of telehealth is going to take the place of thousands of years of human development. We're social animals, and nothing takes the place, I think, of in-person interactions.
So a follow-on question is that, at least for NET patients, we do travel a great deal to see you. I mean, this is about 60-40 that we're traveling over an hour to come to see our health providers or our NET specialists, which I find interesting. And just to give you an idea, the people who have responded to the survey and the people we're going to talk to are mostly been, looking at this diagnosis for a long time. But we do have some newbies as well, and so we'll watch some of our 3-letter acronyms. And there were a couple of questions about exactly what are all of our 3-letter acronyms. And with that, we're going to switch to our Q&A moment. We have nearly 35 or 40 questions. We won't get to all of them, but we certainly will try to get to a few of them. I'm going to start in the imaging world really quickly and do a couple imaging questions. But the first one is something that goes cross-imaging into clinicians as well, because we hear the word SUV, which is a silly, useless value or standard uptake value, depending on how you look at these things. It's another 3-letter acronym that we don't exactly know what it means. And we think that, higher bad, lower good, but really, does this indicate anything other than receptor positivity? And what is its meaning here? And Courtney, I'll start with you, but I'd love everyone else to kick in as well a little bit, because this is a big question.
Sure. Well, a couple quick things. One is that this SUV thing, which is essentially kind of a measure of how intense the hotspot is, it's something that has been really well studied in FDG PET, like sugar PET, and we kind of do know what SUV means in that kind of PET. In somatostatin receptor PET, it's a little different. In many cases, we don't know exactly what that means, and so yeah, the other thing also, as I mentioned in my talk, is that there are many cases in which you absolutely cannot compare SUVs on one scan to another. For instance, if you just had a gallium-60 or previously had a gallium-68 dotatate PET scan, and now you're going to have a copper-64 dotatate PET scan, well, that's different. You can't compare the SUVs. If you had a DOTA-TOC PET scan and now you're having a dotatate PET scan, you can't compare those SUVs. So assuming though you have two of the same studies right in a row, we generally think that it's a good thing if the SUVs of a lesion go down. But again, ultimately, I don't think it's as helpful of a tool yet in somatostatin receptor PET imaging as it is in FDG PET.
Ken, you've been using gallium-68 and dotatate for a long time. What's your look at that?
So I fully agree with Courtney. So, and I'm not even sure that for FDG, for the sugar PET, SUV is such a great marker to take clinical decisions. So, and coming back, and the reason I say, because do we do harm when we say yes here? No, we don't do harm. But the other way is if we say that it's a bad sign if the SUV increases, then we would do something bad. So, in long story short, my recommendation is do not spend too much time worrying about the SUV. Maybe when the number of lesions change, this might be an indicator. But even there, as Courtney already pointed out, it tells you only that the receptors are not expressed in certain lesions. So you should never look at PET alone, number one. Number two is you should not look on the SUV values. If you want to have a comprehensive look at this, you should look at the number of lesions and then only in agreement with the morphological imaging, which could be CT or MR.
And Courtney, you've talked a little bit about this, but I also wanted to talk about word salad again. So you've talked about comparing copper-64 DOTA-scan and the accuracy versus gallium-68, and they're pretty comparable scans, although if you want to comment on that. But the other thing is we do a lot of word salad here. You've called it gallium-68 dotatate. It also goes by a brand name of NetSpot. We have NetDetect. So what's with all this word salad? And and the accuracy versus each other, just a quick reminder for folks.
Yeah, great. I think that there's definitely a good point here about the word salad. It can be tough to avoid. All of these compounds, just like it's the same with any medication as well, right? They all have sort of their chemical names. In other words, they're sort of generic names, and then their brand names. And I think we sometimes find ourselves accidentally using the brand names. I think usually most of us try to use the generic name just for consistency. But so NetSpot is the brand name of gallium-68 dotatate. DetectNet is the brand name of copper-64 dotatate. And copper-64 dotatate, part of why it was FDA approved recently, back in 2020, is that there is data out there showing that it is at least as accurate as gallium-68 dotatate. And ultimately, I think at the end of in fact, there's actually at least one study showing that it may even be slightly more accurate. I don't know that everybody's experiencing that actually out in clinical practice, that it's more accurate, but it certainly doesn't seem to be less accurate. I think, as I mentioned in my talk, it's probably pretty equivalent, but I'll be interested to see how that develops as the use expands throughout the U.S.
So this is one we get. This is, again, word salad, but not necessarily words. It's just words we don't necessarily use a lot. And I think patients are concerned when they see normal physiological uptake, or does that mean it's a false positive? And what exactly is a false positive versus, between that and physiological uptake and maybe noise that you hear on an image as well? So how do those terms get used? And then we'll move on to some of the treatment ones as well.
Well, I don't want to hog this chat, but I do feel I have a pretty strong sense of this one. So the difference between false positive and normal physiologic uptake. So a false positive refers to when you see something and you make an incorrect determination that it is cancer. In other words, you might see normal physiological uptake. For instance, there's a part of the pancreas where about a third of patients just have normal physiological uptake of dotatate. And so in other words, there's a hot spot in the pancreas that's just normal in about a third of patients. So that's normal physiological uptake. It becomes a false positive if the nuclear medicine physician reading the scan says, uh-oh, that looks like a tumor, and it's not a tumor. Does that make sense?
Certainly makes sense to me, but I just wanted to, because we see that word physiological uptake, and then we want to say, well, that does that mean it's hot, and is that a false positive of this exam? And it's not, because you've comprehended what that is as opposed to calling it a tumor. Ken, anything you wanted to add?
So as a very outspoken nuclear medicine physician, I have two comments to this. The first comment is, when we talk about comparison, dotatate, dotatalk, copper, gallium, I tell you one thing, it's all one class of imaging, and I would not make a difference. So I have sometimes patients calling me, should I go for dotatate, should I go for talk for copper? It's a class of imaging. It's much better than octave scan, and what the difference are very subtle. So I would not worry about this. The second thing is, what we do in molecular imaging is we really show the expression of the somatostatin 2 receptor. So per definition, a false positive would be if we see uptake and there's no somatostatin 2 receptor. And this usually is not the case. However, and I think this is what Courtney wanted to explain, I think she did in a very nice and good way, is when we see something, the question is, what do we make out of it? And then if we say something which is not cancer and we make cancer out of it, then it's false positive. But the image itself is not wrong. It shows you somatostatin 2 receptor expression. What we make wrong out of it is if we say it's cancer and it's not cancer. And I hope that the combination of what Courtney said and what I said together helps you.
Courtney, do you want to take that? When will we ever use AI in this world?
It is one of those things that's slow in coming. People started talking about AI, maybe 6 or 7 years ago, and people are still testing it out. One problem that people run into repeatedly is they train these artificial intelligence algorithms, these sort of bots that can read images. They train them, and they do very well on the set of images that they train them on. But then as soon as they get them out into a different population of patients, different kinds of scans, all of a sudden the algorithm falls apart and the accuracy drops a lot. So I think we'll start to see it being artificial intelligence being used more when, one, it is more reliable and can handle more variation from patient to patient, and two, when it is easier to implement, because right now the systems we use to interpret images are in many cases totally different from the software programs and systems that run AI.
And now I'll go to a more generalized question starting on PRT. One of the things I often hear is people who feel pain, whether it's a week or 2 or 6 weeks after treatment, and there's been some people have said that, well, when you feel pain, that means the treatment's working and it's good. Is that the case? And Simran or Ken, when people feel pain, when should they talk to you post-treatment, or how should they approach you with pain? And is this anything to do with the treatment? Potentially with swelling of tumors, but can it be indicative of other things having nothing to do with the treatment?
I mean, you're the expert because you see more patients than me, but I can start quickly. I can say it doesn't automatically mean that it's working, but we have seen indeed patients who benefited from the therapy, that they presented pain. For example, if patients had big liver lesions and they were close to the capsule of the liver, also in certain bone lesions. So it's, let's put it like this, it can be explained by therapy success, but obviously it doesn't have to. Number 2 is, when should they talk to us about it? The moment that you see an increase in pain. We have the advantage or financial disadvantage in Germany that we keep patients for 2 nights. So we usually talk to them when we discharge them. And this is one point where they should definitely give feedback to us in case that there's pain. And in case that it increases over the next 1 or 2 weeks, we would like to hear about it.
Yeah, I would definitely agree. I think, I wouldn't worry so much about whether it means a treatment or not. I think, as Dr. Herman is saying, bone pain can certainly flare up afterwards, and that can be expected. So I think that that is something not to be alarmed about. If there's pain after the treatment, immediately, of course, you want to hear about it. But even weeks after, I think people know their own bodies. And if you're worried about the pain, or if you're worried about some of the symptoms you're having, I think I would speak for almost all clinicians. We'd really want to hear about that rather than not hear about it. It's really important that we have open lines of communication with our patients so that we can understand what's happening. And if there is something going on, deal with it early. But it isn't something that I would panic about if we are, especially when it comes to start to receptive bone. Bone flare-up is well known to occur.
Right, but one thing: the absence of pain doesn't mean this therapy isn't working. I think that's
Absolutely.
right. And just because you have pain, as we said, doesn't necessarily mean it's working. There can be lots of different things that go on there, and I think it's important that we understand that as well. This is back to, and we certainly talked about this at the clinical trials planning meeting, and in many things that we've done. How did we come up with this magic 4 cycles of PRT that are all 200 millicuries? What was what's the either justification, or what are we doing to study to see if that's right? Or are we doing more studies, Simran?
Yeah, so I'll start off, and then, so the 4 cycles of PRT comes from the NETTER-1 trial, and that really is the best data that we have. It was the clearest data. PRT's been done, as much as I like to say this is a really exciting treatment, which it is, it certainly has been done for a time, primarily in Europe. But the way it was done was slightly different, and the way people were doing things were slightly different, standardized. Everybody sort of had slightly different ways of doing it. The NETTER-1 trial brought it all together and put it into a cancer so that everybody could be reading the same page book. And I think where the 4 cycles of PRT comes from. Does that mean that 4 cycles of PRT is the optimal dose for everybody? I don't think so. Some people may benefit from more PRT. Some people have a good response, maybe later on can get more PRT. I think it really depends on their how they responded, what the side effects were. And yes, absolutely, I think we're about to start to see more and more trials being done that are looking now at multiple trials of PRT that are being repeated, or being dose escalated, or what we call dosimetry, which is personalized treatment of PRT. So I think we're moving it on to basically PRT 2.0 as we move forward.
Ken, any thought about that?
So I was trained from 2004 on the nuclear medicine, and back then we did in every patient 6 cycles, and was as arbitrary as the 4 cycles. It's absolutely true what Simran Singh just said about where the 4 come from. What we do also very often is, if a patient after 4 cycles, for example, doesn't show any progression for a year, and then after a year finally shows progression again, we actually retreat patients with another 4 cycles. I always like to say that there's one patient who we treated, and I say we because he was treated in 4 or 5 different hospitals in Europe with up to 28 cycles. So in the end, I think the therapy can be given actually quite often if the patient tolerates it well, but the only evidence so far exists for 4 cycles, and this is where the 4 cycles come from.
Just so people know that, we are looking, I just said, we're definitely either exploring or looking at clinical trials to try to understand better who responds to PRT and when we can give it again. This is going to be an important step forward for all of us.
Yeah, there's a retreatment study coming soon.
Yeah, and there may be more than one, I hope, and by different people as well. So one of the things I get, and we see this in PRT questions, but probably it's in other therapies as well, and maybe it's just over time as well. Grade progression, people who may be a grade 1, and then 4 years after PRT, they are rebiopsied and they're a grade 2. Do we have any evidence that this is something that might happen from PRT or other therapies? And do we see a lot of grade progression in NETs in general and or with specific treatments? And this is probably a big, broad question to which doesn't have a lot of clinical trial data, but I'll throw it out there and see if anyone wants to bite on that.
Start. I don't know of data about grade progression following PRT, and maybe my co-panelists, but I think the idea of grade progression does occur in neuroendocrine tumors. We've had some, looking back at our data here in Toronto, it's somewhere around 7% of patients patients, in fact, have had some grade progression. Sometimes it's simply a matter of a change in staining, but sometimes it can be a quite meaningful change. And so I would say generally, when the rate of progression, whether it be post-PRT or not, when it really doesn't fit the clinical picture, what we expect out of the prognostic or factors that we have, that would be a good time to re-explore the grade and maybe do a re-biopsy. We generally take that approach when what we expect to see happening isn't happening.
Ken, any thought?
Dr. Singh, yeah, I fully agree with Dr. Singh. So what we never know if it's really grade progression or not, because very often it's two different lesions which are biopsied. What we do see indeed is that we have an initial Chi-67, which at a later time point, when there is a lesion which, let's say, behaves a little bit separate or different than the rest of the lesions, we rebiopsy them and then we find a higher grade. This is something, like Dr. Singh said, which I think is not unique to PRT. I think it's sometimes typical for the tumors, especially when the patients we follow over many years, that there is maybe a different lesion or a different cell clone all of a sudden leading the disease drive. But like Dr. Singh said, there is no real hard data on this, because I think 7% is a number I could live with from what we see in the daily clinical routine. So it's not very common, but the classic is what we see, and where we do it is a patient where we see that actually the dilatate or the TOC signal is lost, but the morphological lesion gets bigger. This is one of the lesions where we are worried that the lesion is dedifferentiated. And these are the lesions where we either perform an FDG PET to see if this is still a viable lesion, or we directly biopsy them. And in these patients, we do actually sometimes see indeed in higher Chi-67 than we have seen at the initial diagnosis.
I'm going to go back to another thing of more word salad, but in TAT, which is just PRT with an alpha therapy, so targeted alpha therapy, which is what TAT means. Is that going to be something? Are we looking at that for post the 4 cycles of a beta emitter, or do we see that as being maybe a first line or a first line PRRT, or where is this? I mean, we've talked a little bit about follow-on PRRT, and Ken, I don't know if you're working with alpha in your area in Germany as well, but what do you see coming down the pike? And I know you talked a little bit about it, you and Simran, in your talks.
So TAT or alpha PRT is definitely something which we have to watch in the future. So, for example, in Essen, we do use alpha, but for prostate, not for neuroendocrine tumors yet. We do need a clinical study there, because, to be fully honest, yes, it's very promising regarding a quite high potency of efficacy, but it also has a different toxicity profile. And especially in neuroendocrine tumor patients, where the expected life at time of our treatment is much longer than, for example, for prostate cancer, where we do this treatment at a later time point, we really need to be sure what we're doing. That's why I'm fully supportive of using alpha PRT within clinical trials, because there we can closely and prospectively monitor not only the efficacy, but also the tox profile. But I'm not a big fan right now of patients who had 4 cycles traveling somewhere to a place where they can offer it outside of clinical studies. Because of, like I said, we really need to understand the tox profile.
I totally agree. I mean, it's a promising new area, but I think when it comes to neuroendocrine tumor patients, I mean, we really need to make sure that we put the patient at the center. Toxicity really matters. Many people are going to live many more years, and that's really important. So I'm completely in agreement. I think we need clinical trials. The best data I know of comes out of, there's a study that came out of New Delhi, for example, that showed some efficacy, but it's small. And I think we really need to have proper clinical data to understand if this is a promising, and if it is, who is it promising for? It may be that there's some patients where this is a really promising, and other patients where that balance between, treatment and toxicity, it just doesn't work for them.
I'm going to take one because I actually wrote something for the JNM on this one. You mentioned concerns when traveling post-PRT. Can you elaborate on what we might expect? Certainly, if you're traveling internationally, especially back into the to the U.S., you will run into Homeland Security that will actually have Geiger counters that go off, or different monitoring devices that you'll have to show your card and walk through this. And that can last for nearly 10 half-lives post when you had the treatment. So in the case of LU-177, that's about 67 days. And this is something that patients don't remember because we got treated so long ago that, we're on a cruise to Mexico or something, and it can happen. It can also happen when you're near bridges that are monitored by Homeland Security. So these are some of the conditions. And from a radiation safety standpoint, I mean, one of the questions in here as well is, if we're traveling by airplane, how long, and Courtney or Ken, you can chime in, how long before we can travel on an airplane or public transportation?
So at least in the U.S., per federal law, it is legal as long as you are giving off below a certain amount of radiation. It's legal for you to be out in public, and the government actually has a certain number of how much radiation you're giving off, at like below which it's safe to be out in public, including using public transportation, taking a plane ride, things like that. In generally, no, I have to say in all cases, Lutathera does. You never reach that threshold of, ooh, this person is going to be dangerous out in the public, is going to be a radiation hazard out in the public, which is why we generally don't even measure the amount of radiation you're giving off right after we give PRRT, because we just know it's going to be so far below that threshold. Nevertheless, the detectors that they have at places like airports can be super, super, super sensitive. They detect way lower than that sort of danger threshold that's out there. And so, yeah, we ask that patients, we have a little form that lets anybody like the TSA or anybody else know, oh, this patient had this treatment per federal law. It's safe for them to be out in public traveling. If you have any questions, contact our radiation safety personnel. We have our patients keep that form, a copy of that form, with them, like in their wallet or whatever, for 2 months after the therapy, just in case. That being said, I've treated patients who've gotten on a plane as early as the next day and not had a problem.
Yeah, no, and certainly it's an international flight because TSA doesn't actually have any of the fancy gear. It's only Homeland Security that has the gear. So it's when you go through international parts and international detectors that this happens. Getting back into timing of therapies, often, and certainly when this was first in the U.S., this was considered a last resort type of treatment. And obviously the European experience was that as time moved on, it moved more forward. So this is how do I know that this is the right path for me? And should this be considered the last option for someone? And Simran, I'll let you start first.
So I think, as you said, I think the traditional thinking, especially in North America, was this was a late option or a last resort option. And I think that's changing. Again, it really depends, and I hate to be repetitive here, but it really depends on the patient. It really depends on the tumor in terms of how aggressive the tumor is. Does it have receptors? What is the patient's scenario? What treatments have they tried? What are the other treatment options? Certainly, the NETTER-2 trial is looking at slightly more high-grade tumors and trying to understand if moving PRT early would be of some advantage. And I think, as the data comes through, we'll sort of understand that a little bit more. There are some sequencing studies that are also going to help us understand this that will come through. But at this point, I think it really depends on a person-to-person basis. And I think there's some standard therapies we know, for example, in small bowel tumors, the best treatment probably after somatostatin analogs is probably PRRT. In other situations, depending on the grade of the tumor, it may vary. So it's an important discussion to have with your healthcare provider.
I fully agree with Dr. Singh. So for us in our center, GI nets and do not include PNET there. It's pretty much second line after somatostatin analogs. So and this is not very late. So I think this is the case for PNETs. It's like Dr. Singh said, the data is not as clear. So we discuss each individual patient. but they are actually quite often we do this also in second line, or for example, streptococcal review. Definitely, I also believe that PRT might play even a role in neoadjuvant setting. There is some preliminary data from Erasmus available, but this has to be done now in clinical prospective trials to really understand what is the right sequencing. But overall, the idea PRT means that I have nothing left after. It's not true anymore. I think it's a very potent, good treatment and at earlier lines.
But thinking about that, this follow-on question is that are there treatments that are counterindicated, or that by having one you can't do the other? Do any of these treatments eliminate the path? And I know there was some certainly early data out of Penn, but that seems to have been with really heavily pretreated patients as well. About serospheres and theraspheres, and I know there's papers out of Germany that says these things can follow each other. So thoughts?
I can maybe start. So there's a very interesting study from the Netherlands, interestingly not using serospheres nor theraspheres, but holmium. But again, it's same mechanisms, same thing. And there it showed that actually both of them work together very, very well. It's a prospective phase 2 study, I think, headed by Manik Salam and his team. And this shows that this works very well together. And it's pretty much also what we do now currently here. We do actually theraspheres, most of the patients, but we do not see any contraindication.
And Simran, this is one that you've talked about, but the future, or what has been the success so far? I know we've had a few studies on that have combined PARP inhibitors and other chemotherapies. I know that we had the ControlNet trial that showed out in early 2020. Do you want to, you talked about this as part of the clinical trials planning meeting, but any other comments that you want to make about these combination therapies? And I'll make the preface that Ken's going to make in about 30 seconds. All of this should be done inside of a clinical trial and not as a one-off. So I'll do that. I see you smiling already, but Simran.
Ken's a smart guy. He knows what he's talking about. So I agree with him completely. This is really clinical trial area. I guess the way to look at this would be in a couple different ways. One is by combining therapy, are we getting better results? And I think so far, I'd have to say I don't have data to prove that yet. The ControlNet study showed basically that by combining chemotherapy with the trade-off was a lot of increased toxicity. Now that might not be all the case. That was one small study, small number of patients, at least studies we looked at. Part of it may be, can we make PRT more effective? Or the other flip side of that, PRT make the therapies other therapies more effective. So one of the challenges from my point of view has been immunotherapy. The rest of the cancer world has really seen immunotherapy that unfortunately we haven't been able to realize as a neuro community yet. And there is some possibility that PRT may create an environment where immunotherapy itself may be more effective. So not only is the PRT acting upon the tumor, but it's creating an environment where immunotherapy may actually now be effective where it isn't on its own. And so that's what I see as exciting. And I do think as we move forward, we're going to see trials looking at that. The idea of, is a 1-2 punch better? Perhaps, and as Dr. Herman was saying, there's a lot of these tumors are very heterogeneous, meaning some of them are different grades, some of them are a little bit more, are growing a bit faster than others, some of them have different qualities than others, maybe also where combination therapy might be promising. Maybe PRT treats some of the cancer cells and some of the other therapies can treat some, we can get a better holistic picture. So there's the additive effect, logistic effect. And so as we move forward, we balance that against toxicity. But again, it's really a clinical trials area right now.
I'm going to ask one last question. This is the last question, and it's more of a crystal ball question, and I will only bring this up a couple of years down the road. I'll bring up this tape to see how close we were, but your idea of when we might see another PRT approval. Courtney, any guesses? You can just throw out a year, and we'll bring this up in the archives.
I'll say 2024.
2024, and my son just dive bombed in, but that's okay. That's why we're live. So we got 2024. My dog was almost dive bombing in here as well, but and Ken, we got 2024 on it.
So if you accept DORA-TOC as a new PRT, then I hope 2023 compete, right? This would be something I would hope for. If we talk about an alpha or even a new, let's say, a new ligand, which means an antagonist or, for example, even a different receptor, then it's probably more 5 years from now. But let's see.
All right, 2026, 2024, and 2023 on a DOTA thing, and Simran.
Well, I'm trying to think about the prices right. I sort of know how to balance. So I'd have to say 2026 or above would probably be where I go, and then I'll cover the most of the bases there.
I think
You're a smart guy.
this is an all-challenging thing, and I'm going to refrain since I got to ask the question, but I kind of I'm probably along the lines of Ken's thinking as well. And I really want to thank you. It's really fun doing this among friends and among people that you wish you could see, not in the flat Earth, but in the real Earth. And I hope to be able to do that again sometimes. And with this, I'll turn it. Again, thank you, and thank you to Rebecca Miro, who is hopefully on a plane somewhere, flying to a vacation, and to Bill Claxton, who joined me in person in this studio here. And with that, I'm going to turn it over to our host to the studio to close the show.